coffee and cardiovascular. Could be a
That's a
bad
great
combo.
combination.
Great segue. Guys, we're gonna do cardiovascular emergencies first. We're gonna review anatomy at the beginning. Go back over that blood flow that I'm sure you guys need review for. So we're gonna go back over A&P. It's gonna be a review. I'm not gonna spend a ton of time. This should not be introductory material. We've already gone over that during human body, and then we're gonna jump into what happens when things go wrong. All right. Okay. All right, tell me about the heart. What does it do?
Moves blood around.
Huh?
Moves blood around.
Moves blood around. Okay, tell me about the structure of the heart. We've got 4 chambers. All right, what are the upper chambers called?
Atria.
The atria, and the lowers are the ventricles, and we have 2 sides. What are the 2 sides?
The left and the right, shockingly enough.
The right and the left side. All right, and what is that structure that divides the right for the left? The septum. Okay, so guys, what is the septum really important when it comes to what for the heart? The electrical conduction, right? Most of all of that conductive pathway travels through that septum. So that'll come back up a little bit later on, but just remember that. All right. So tell me about the blood flow through the heart. What do we have in place to make sure the blood flow goes like it should? We have valves. What kind of valves?
One-way valves.
One-way valves. They're specifically designed to make sure that blood flow goes in one direction throughout the heart, because if it starts to back up, we start to see problems. So if we have a defective valve, then we can start to see signs and symptoms presenting in our patient depending on what valve is not working correctly. All right, let's go back over blood flow. Where do we start? What are our main dumping tubes?
Vena cava.
What vena cava?
Superior and
Superior and inferior vena cava dumps into the right atrium, goes through the tricuspid valve to the right ventricle, through the pulmonic valve to the pulmonary arteries, all right, which dump into the lungs. What happens here? Gas exchange, all right, so we turn into the pulmonary arterioles, right? So we're in the pulmonary arteries, we go to the smaller arterioles, to the capillary beds, all right, back to the pulmonary venules, to the pulmonary veins, all right, and they dump out where? Left atrium, goes through the bicuspid valve, aka mitral valve, to the left ventricle, to the what? Through the aortic valve to all of the systemic arteries, to the systemic arterioles, to the systemic capillaries, to the systemic venules, systemic veins, back to the. That was not as rough as I thought it would be. All right, good job, guys. So, especially, guys, I know I've said you've got to know normal before you know abnormal, but particularly when we start talking about congestive heart failure. All right, today there's 2 different types, and we need to understand the normal blood flow so we can understand why these patients present the way they do if they have a certain type of heart failure. Okay, questions, comments, concerns on that? Do you guys want to watch the video? Yeah. Oh no. Hold on.
I hear something coming from above my head. Just very quiet. Just really quiet.
Stand by.
Take it easy. Let's get started. Oxygen for blood returns from the body to the heart. Blood returns to the heart via the superior vena cava and the inferior vena cava. Once it enters into the right atrium, after the right atrium is filled with blood, it contracts, which opens the tricuspid valve. Blood flows from the right atrium through the tricuspid valve and into the right ventricle. Once the right ventricle is filled with blood, the tricuspid valve is forced closed, and the right ventricle contracts. Blood is pushed through the pulmonary valve and into the pulmonary artery, which go to the lungs. In the lungs, the blood undergoes gas exchange and becomes oxygen-rich. Oxygenated blood flows from the lungs back to the heart by way of the pulmonary veins and into the left atrium. The left atrium fills with blood and contracts, opening the mitral valve, filling the left ventricle. The left ventricle contracts, which opens the aortic valve and forces oxygenated blood through the aorta into the rest of the body.
Okay, so you guys just make sure you've got that down pat. It's like the 5th time we've brought it up and talked about it, so hopefully some of it's sticking. Everybody go with that? Okay. All right, so the electrical system, guys, we've already kind of talked about this a little bit. We brought it back up again with AED, right, during CPR day. But tell me about the electrical system. What does it do? What's some of its components? What do you guys know about it?
Controls timing and heart contractions.
Okay, so everything has to go, that electrical impulse has to go the same exact way at the exact moment it's supposed to, so we see that normal contraction of the heart, right? If we see maybe there's a delay in the response system, or there's like a roadblock set up and that electrical current has to bypass the normal route, we start to see what?
Well, bad things in general, but
Bad things. But what do we see? What are they called? Dysrhythmias, right? Because that normal rhythm, that normal what we call sinus rhythm, looks like this, something like that, right? We got a hump, we got a big spike, we got another hump, and then we go back to a straight line and it starts all over again. If we see that squiggly line, we know everything's working in the right way, there's no roadblocks, everybody's going on time. If we start to see variations in that squiggly line on that cardiac monitor, we know something is off. Okay, so where does this electrical impulse start? The SA node, what does that stand for? Sinoatrial node. Where is that guy located? The right atrium. Okay, so the SA node is the heart's what? Natural pacemaker. Okay, so the SA node is going to decide based on all of the different things we've already talked about, hormones, response systems that are hardwired into the body, particularly that sympathetic and parasympathetic nervous system. All right, that SA node is going to decide how many beats per minute the heart is going to contract based on everything else in the body. Okay, where does it go to next? So-ish, not yet. We start to go towards the septum with the AV node. What does the AV node stand for? What is it in the middle of? Right at the joint of who? The atria and the ventricles. So it's the atrioventricular node. Okay. That's the next stop in the electrical system, or the conduction pathway. What does the AV node do? Okay, so the stimulus for, yes, that comes from the AV node, but what overall does the AV node, what is it in charge of?
It makes sure there's time between contractions to rest.
Okay, so it kind of says for that microsecond pause, it says, okay, before you guys pass through me, I need to make sure everyone's on the same page, everybody's had time to do their job, and we're on the right pathway to have a normal contraction. So there is a millisecond pause here at the AV node before it says, okay, everybody's done what they need to do, everybody's on track to do what they need to do, so let's continue through that kind of electrical pathway.
So that brief period of time ensures the chamber's drain through.
Correct. Yeah, at this time, we see the atria contracting, those valves opening and closing correspondingly. But yeah, just making sure everybody is on the same time frame. Okay, guys, then we travel down. So notice where we are now. What is this big chunk? This is the septum of the heart. Okay, so we're going through the bundle of his. We notice that we start to branch off to the left and the right. Okay, so you have a left bundle branch and you have a right bundle branch. All right, so once we bifurcate off to those branches, we start to kind of come down here and we wrap around the ventricles, and then we get down to these Purkinje fibers. Okay, really, really important that we get down to those Purkinje fibers, because as it's wrapping around the ventricle, those are in charge of actually doing what for the ventricle? Causing that physical contraction, which leads to cardiac output, which leads to perfusion, all of that good stuff, right? Okay, so we go from the SA node to the AV node, down the bundle branches, okay, and then we wrap around the ventricles with the Purkinje fibers. Know that the SA node is the heart's normal pacemaker. AV node kind of says, hey guys, let's take a second, make sure everything's contracted, everybody's on the right pathway to do everything normally, and then releases the rest of that electrical stimulus through the septum, bundle branches, and the Purkinje fibers. Guys, how does the heart do this?
Magic.
Right? What is a very cool, distinctive feature about cardiac cells that is nowhere else, found nowhere else in the body? Okay, so what's that word? Automasticity, okay? That means that we don't have to walk around plugged into an electrical outlet all day, every day for our heart to beat, to have that electrical stimulus, all right? That feature, that property of automasticity means that these cardiac cells can develop their own impulse and just generate their own electricity by themselves. Freaking nutso. All right. Okay. So guys, this is important too. There is kind of backup systems in the heart. So let's say maybe the SA node is not really firing like it should be, or we're skipping a couple beats. The heart can kind of, because we have that automasticity property, it can kind of pick up and say, okay, you know, we're going to leave this one part out of our electrical pathway, but it's not going to be a normal heartbeat. It's still going to be a dysrhythmia, but the heart can attempt to kind of have that contraction and kind of pick up where whatever part of that conduction pathway left off by itself. Okay, but if we don't have all of those components in play, then we're going to start seeing irregularities when it comes to that electrical presentation of the heartbeat. Okay, am I good?
At Macy's, we're excited to welcome you back to our stores with extra precautions to keep you safe and added contact-free curbside pickup at select locations, so you can get your purchase quickly and securely. Find a participating location near you at Macy's.com/stores.
For SA node, the cardiac conduction system consists of the following components: the sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA nodes to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
Okay. So that went more in depth of what you guys are going to be expected to learn throughout this course. Okay, talking about each of those parts of the squiggly line and what they represent for the heartbeat. That doesn't come along until you get to paramedic. Okay, that's part of your scope as paramedic, to be able to look at an EKG, all right, and look at the variations in those squiggly lines, the spacings, how high these peaks are, all of this stuff, and say, oh, okay, based on what this looks like, I can tell this is what's going on in the heart. Okay. I'm kind of a nerd about cardiology, so I give you guys more information than you're going to be required to know, but you know, it's not going to hurt you to know more stuff. So we'll get to that a little bit later, but just an introduction to see that it is crazy but complicated but cool that we can look and say, oh, because there's a delay in the PR segment, that means you have a first degree heart block. Okay, so just nerd out a little bit.
Is there like an additional class or certification training we can take? Or not?
Paramedic course.
One of those.
Guys, you cannot interpret an EKG until you get through paramedic. You can't interpret anything as an AEMT. This is where paramedics actually have a higher scope of practice than an RN, because an RN cannot interpret a 12 lead, but paramedic can. All right. So when you get to, because guys, I want you to know the baseline stuff. Hey, that doesn't look normal. Like when we talked about that ventricular fibrillation and ventricular tachycardia during CPR, I want you to be able to look at the monitor and be like, those lines don't look like they should, right? But it's that in-depth interpretation doesn't come until a paramedic. So you can have an introduction. Like y'all can take an ACLS class, which is Advanced Cardiovascular Life Support. As a basic EMT, you can take an ACLS class, but it's not going to cover drugs within your scope and interpretations of 12 leads and stuff. But you can have knowledge, you just can't practice it until you get a paramedic. Do with that what you will. All right, guys, do I need to go back over this automatic or autonomic nervous system, that sympathetic versus parasympathetic, the fight or flight, how that has different responses to your vital signs, including your heart rate, including, you know, how hard and how fast your heart contracts. Everybody pretty okay with that? Anybody in Zoom land? Okay, so guys, this is, again, when I was talking about that SA node, that natural pacemaker, it picks up on these hormones that are released, right? If what hormone is released during fight or flight, if that epinephrine is released, that communicates with that SA node and says, hey, I'm here, let's increase heart rate, let's increase the strength of the contraction. So that SA node functions, if it's functioning normally, right, if it's healthy, it picks up on those cues from the hormones, all right? When that parasympathetic kicks in, all right, it also understands from the messages from the body, okay, I can slow the heart rate down now. I don't have to, you know, contract as hard. It works based on the hormones in the body. Okay? So guys, remember the heart cells, the heart muscle are cells and muscles themselves, right? They have to themselves have the oxygen-rich blood supply. So we have different arteries that wrap around the heart and supply those cells with that oxygen-rich blood. Guys, the heart actually gets first dibs. All right, that the second it comes out of the lungs, that super saturated O2-rich blood, all right, goes straight to the coronary arteries before it goes anywhere else in the body. So we can make sure that the heart is getting the oxygen and the supplies that it needs to do this very important job that it has for the body. Okay, so don't forget that, because when that starts to get disrupted, that's when we start to see heart attacks. That's what causes heart attacks, is obstruction of that blood flow to the heart cells. All right. So guys, we're just going to go back over the definition of stroke volume. What is stroke volume? Okay, so every single time the heart pumps out, the amount of blood that is pumped out during that process is the stroke volume. Okay, does anyone remember the formula to achieve your cardiac output number?
Stalagmitis minus systole.
Right? Stroke volume, the amount of blood moved out in one contraction, times
Contractions per minute.
your heartbeat per minute. That's technically your minute volume, right? How much blood your heart is pumping out in the course of a minute, but that's what we look at for cardiac output, right? Is that blood supply, that output, sufficient enough for that big P word? Perfusion. Okay? All right, so again, guys, we have arteries that wrap all around the different sides, front and back, left and right of the heart. So just understand these little joints right here. If we get a clot right there, that's bad news for your heart, right? But anywhere in this artery branches that cover your heart and supply your heart, if we get an obstruction, if we start to see that hypoxia to those heart cells, those cardiac cells, that's when we start to see a heart attack, and we'll talk about that in just a little bit. Okay, so but I just want you to be clear, it's not just one main artery that supplies blood to the heart. It's a bunch of different branches that wrap around. Okay. All right, so arteries, guys, that go to the rest of the body, right? So those systemic arteries, where's your carotid? Please tell me you know this. Okay.
It's on your neck, side of your neck.
Right. Where's your subclavian? Okay. Okay, below your clavicles. Brachial.
It's in the upper part of your arms.
Really like, right? We use that to especially to find our what vital sign? Blood pressure. Radial.
Your radials in your wrist.
Ulnar. Pinky side. Okay. Iliac. Okay.
It's in the pelvis.
Branch off or bifurcates from that descending abdominal aorta to the iliac, to those femoral arteries. Okay, that's where we have a pelvis injury. It can cause a bunch of damage. Femoral.
The diamond is the femoral.
Posterior tibial.
It's going to be in your ankles.
We also have the what? The what? The fancy pants term for it? dorsalis pedis. Okay. Everybody's good with the definition of an arteriole, right? The main goal of an artery is to get that blood flow or to get that gas exchange from that really big tube, the wider tube, the artery, down to those capillary beds, right? The arteriole is just a smaller version of the artery to get to those microscopic capillary beds. And then we have the smaller version of the vein, the venule, to get back to the wider veins, to get back to the heart eventually. Okay.
Most of the place down the road, like nice brain surgery, they're actually doing work on the heart.
Typically, yeah. All right, so the superior vena cava brings back the blood from what part of the body?
Everywhere.
Superior vena cava, right? That's bringing back all of that blood. We've already passed out all those O2 molecules, and it's bringing back that deoxygenated blood from the upper half of the body. So that inferior vena cava is bringing back that deoxygenated blood to the heart from the inferior, the lower part of the body. Right, we go back over our blood stew, right? What's our blood stew made out of? What's my red blood cells? What's that ingredient? Huh? What ingredient? Ingredient, do you guys not cook?
Potatoes.
Yeah, it's part of the stew. Yeah, so let's say there's potatoes, right? The red blood cells are my potatoes in my blood stew. What do?
Carry oxygenated blood through the body.
Right, but the red blood cells actually have those seats on them to carry oxygen, to give out to the body. All right, how many seats do we have? 4 O2 molecule seats. Okay, what are the onions in my blood stew? White blood cells. What do?
Destroy foreign substances.
Okay, so they are a main part of the army of my immune system, right? If I have a foreign invader, such as a bacteria or a virus or something like that, those white blood cells get activated, they go to that site and they try to fight it off and kind of like literally like encapsulate it and try to eat and deteriorate and get rid of the bacteria or the virus. What are my carrots in blood stew?
Your platelets.
Okay, my platelets, what do?
They help stop you bleeding out, like they help your blood clot.
They contribute to the ability to clot. So if we get a small little cut on our hand or, just something that's not life-threatening, it's not life-threatening because those platelets go to that site, they clump together, they stick together, they form a clot. Our body heals from the inside out, a scab forms, we create new skin, we're good to go, right? So normally we like platelets, right? We don't want to bleed out from a minor injury, but platelets can start wreaking havoc in what particular cardiac event? So yes, an embolism, but which would lead to what? An embolism in the heart is going to lead to a heart attack. Okay. And then plasma, the broth that everything floats around in, right? It's just kind of that connecting. It keeps everything together as a
secretion.
Sorry.
The secretion.
Secretion.
Yeah, it's I guess I'm using the right word. Like it's that secretion that helps the blood cells get to where they need to be.
Yeah, it helps be able to kind of like move everything as one unit. Plasma also does directly contribute to our fluid levels in our body as well. Okay. That plasma, remember guys, if you ever get like a road rash or like a very superficial injury, it's kind of like a yellowish, clearish. Yeah, particularly if you get like a tattoo, it kind of is weepy for a little bit. That's that plasma kind of coming out. So that's what plasma looks like. All right, tell me about blood pressure. We talked about it in theory. You should kind of, in theory, know how to be obtaining a blood pressure. What am I hearing or seeing with that number that represents a systolic measurement? What is happening for my systolic measurement? Okay, so I am measuring how forcefully that left ventricle is having to contract to pump through those arteries to go to all of my systemic arteries and capillary beds, right? How hard it's having to pump to overcome any what?
Systemic vascular resistance.
Systemic vascular resistance, right? If there's two forms of that. We're going to get to a specific slide about those. But if there is a form of resistance in my vascular system, that left ventricle is going to have to pump harder to overcome that obstacle to make sure my body still gets perfused. That's where we start to see high blood pressure, right? But yes, I am measuring directly how hard that left ventricle is having to work, having to pump, having to contract to properly perfuse my body. All right, what's the diastolic? So this is just kind of just the residual pressure that's letting me know like everything's having the appropriate time to rest, refill, and kind of gear back up to provide that consistent, proper perfusion pressure. Okay. How do we know what our systolic number is? Systolic? Right, that very first distinct, yes, I heard that pulse. When we hear that, we're going to look at that gauge and see what number that gauge is on. That's going to tell me my systolic. And my diastolic, the very last, yes, I heard that one for sure. That's going to be my diastolic. Because remember, guys, it can kind of fade in and then it can kind of fade out. So the very first, very strong pulse and the very last strong pulse you hear. We're going to do a measurement. Could be.
120 to 80 is normal, so what do you like on that? I was looking up, so I read that above 130 could be a beginning sign of hypertension. Right, I don't want to be talking about this stuff, right?
So guys, textbook perfect, that perfect range or that normal range is going to be what? 120 over 80. All right, so just like we talked about the blood sugar, okay, what's the normal range for a blood sugar?
80 to 120.
80 to 120, right? If you come up to me, I haven't had breakfast, I haven't had a coffee, whatever it might be, and my blood sugar is a little bit lower, technically that is, if it's below 80, it's technically hypoglycemic, but that could be normal for me. It could be a normal reading because I'm not, by the way, I would die, but like intermittent fasting, right? Or you could have someone who's a diabetic who doesn't control their sugar very well, and you get a measurement of 250 or 300. Okay, but that can be normal for that person's body. So yes, you can have fluctuations. That's why I'm encouraging you guys to do several different people when it comes to your vital signs, especially if you're like an athlete. All right, if you work out a lot, if you run a lot, what do you think your normal vital signs range is going to be? Okay.
Your blood pressure is going to be a little higher.
Mm-hmm.
I mean, wait.
Because guys, the heart is
lower. Excuse me.
The heart is a muscle, right? If you condition your muscles, right? If you go to the gym and you're consistently working out, whether you're trying to like bulk up or tone or whatever you're doing, but if you're consistently working out and conditioning your muscles, what starts to happen to your muscles? They start to be stronger. They are more efficient. They look better, right? Guys, your heart, you can train your heart. You can condition your heart as well. So if you are consistently doing cardio or running or doing any type of physical exercise, your heart is getting used to that strenuous activity, and over a little while, it's not going to have to work as hard to perfuse because it's like, oh yeah, dude, I'm nice and toned. I got this. So if you see someone who is an athlete, it is very likely that their blood pressure is going to be lower than that 120/80 mark because they've been conditioning the muscle of their heart along with the rest of their body to say, hey, I'm in prime condition right now. I don't have to beat as hard anymore to perfuse because, we've been training for this pretty much.
So at what point, like above normal, would you actually start to be concerned?
If they're being symptomatic. Now, if I get a reading of, let's say, like 180 over 94, something like that, that's high. If I take a step back and say, hey, do you have a history of high blood pressure, or do you know what your blood pressure normally runs? If that's high for them, I would be like, okay, if you're not having any of these signs and symptoms that we're going to talk about in a little bit that make me concerned, I'm going to go follow up with a doctor. You might want to see if this is like a chronic thing you might want to start medication for. But yeah, if it's like
Yeah.
200s,
My grandmother was pretty high, it was like 170.
did they have a history of high blood pressure?
I got a 170 as well. She denied having a history of high blood pressure, but seemed very familiar with what high blood pressure felt like. So I think she was lying to me.
So again, you could have a patient who has a normal higher blood pressure. Doesn't mean they're having a what we call a hypertensive emergency, but their body's just used to, you know, bad genetics, bad diet, no exercise, and it acclimates just like somebody who conditions themselves would acclimate. If you have an athlete, their heart rate could be in the 50s, and that's normal for them, right? So that's why you got to treat your patient, not your equipment. Right, if you get a significantly lower than normal reading, take a step back. Does your patient look like they're in hypoperfusion? Does it look like they're in shock? If not, hey, do you run? Do you work out a lot? Do you do this? Do you do that? Okay. Also, guys, smaller framed people, like if they're very petite, if they're short, they have not a lot of like body fat on them, their body or their heart doesn't have as much surface area to supply perfusion to, so they can run lower in heart rate and blood pressure as well. So take a step back, look at your patient, and if they seem fine, like they're not in shock, but their systolic is 88, okay, cool, good for you. All right, so everybody's clear that when we palpate a pulse, we're physically feeling that blood pushing up against the artery wall as it's being forced through the arteries.
Yep.
Different pulse points. Okay, guys. We're really going to be using these the most in adult patients. When we check what we might use these to.
We're checking an infant.
Lower extremities.
Circulation.
What do we check? What acronym do we use? That includes this? PMS.
PMS.
Right? So for upper and lower extremities, but the lower extremities for PMS, that posterior tibial, the pedal pulse. Who are we going to use this on? Kiddos. Okay.
Do you ever use the femoral really for anything?
You'll see them use it in the ER. Like if you bring in a cardiac arrest patient or a really, really, really critical patient, they have a machine called a Doppler machine, and they can put like the gel stuff on it, and that can, if they can pick up the sound of a femoral pulse, then they know that perfusion is adequate. Because if you have a femoral pulse, then you definitely have a carotid pulse. Pulse motor sensory. Brachial.
I've watched a couple of videos now and
So you got to remember too, when we find these pulses, we're pushing these arteries up against a solid surface, which is typically going to be the bone that they, you know, set up against. So if you're pushing all the way up here, you're not pushing up against anything but muscle. So just imagine where your humerus bone is, and then just kind of, again, that big muscle right there in the arm, there's just kind of like a groove that it kind of falls into. It's just repetition. Stuff. Talked about cardiac output. We talked about getting these formulas. Guys, do I care about these numbers in the field? Do I care about these formulas in the field? You need to know them. Yes, we do need to know them. But what do I care about? An adequate perfusion, an adequate blood pressure. Right? If my patient is not pale, cool, clammy, blue, anything like that, if they are that warm, pink, and dry, then I know that cardiac output is sufficient, right? I can, in the back of my mind, if my patient is that pale, cool, clammy, be like, well, I know their cardiac output is not sufficient, but I just want to know, is my patient perfusing? Okay? We will find that number reflected in the blood pressure, right? We get a blood pressure, we'll know those numbers are adequate or not adequate, but we don't calculate this formula in a pre-hospital setting.
How do you actually like accurately calculate the number, like in a hospital setting?
An
Like,
echo, like you have to get the ultrasound machine and look at the heart and do it with that diagnostic tool.
Okay.
Really expensive. Okay. Guys, what is this fancy pants word right here? Ischemia. All right, what does that mean?
Decreased blood flow.
Decreased blood flow, which subsequently means decreased oxygen supply. Right. Okay, you're going to hear this term ischemia come up today when we're talking about heart attacks in particular. And then also when we go over neurological emergencies, you're going to hear that term as one of the two types of strokes that we see and need to know about. So ischemia is a fancy pants term for lack of blood flow, which means lack of oxygen. Okay. How do you think we see ischemia? What has to be present for ischemia to be at play? Clot, right? An embolus of some sort has to be blocking that normal blood flow, those normal arteries, the branches, all right? So whenever we see ischemia, we've got a clot involved.
Also, a really bad hemorrhagic shock, sort of at least.
Instructor A,
Yes.
would you say that most of the neurological emergencies that we see in the field is like nervous system based rather than like brain problems?
Not really. I mean, that is at play, yes. But yeah, we start to see computer issues, if you will, with the brain. So sometimes that triggers an abnormal response for the nervous system, but a lot of it is like the brain itself and the actual functions of the brain.
I gotcha.
Okay. All right, so going back to that systemic vascular resistance, all right, these are the two types we're going to see, the two things that occur to create that systemic vascular resistance. All right, what's the first one? Atherosclerosis. Guys, what does this mean? What's happening here?
Buildup of cholesterol on the arterial wall.
This is where we start to see that nasty, ooey gooey, sticky plaque build up inside the arterial walls. All right. So literally, if you ever go to the dentist and they scrape that stuff off your teeth and they wipe it on the little bib that they put on you and it's just like tacky and just nasty looking, that's what's inside your arterial walls. I mean, not exactly, but very similar. Has the same properties. All right, how do we see this plaque develop? So you can see it's represented as a yellow gunk right here. Over time, but poor diet, right? If y'all are, eating nothing but fried food, red meat is another big culprit, but just very fat, oily, saturated foods, that's a major part of your diet day in and day out, then this can start to accumulate. All right, what else? Lack of exercise, right? Because guys, when you go out and you do cardio or you do any type of like intense physical activity, what starts to happen in your body? Your heart rate goes up. What else goes up? Your blood pressure. Because that's why when you start like to break a sweat, when you're really getting in that good workout, you start to get kind of red and flushed to the face because your heart is working harder and that blood is moving more forcefully through your vessels, right? If you're doing that consistently, even if you might have a poor diet, right? If you're starting to have some of that plaque develop, if you're consistently working out and forcefully pushing that blood through your arteries and your vessels, it can kind of displace that plaque, it can get rid of it. Okay, so a sedentary lifestyle, if you are not doing physical activity to increase that blood pressure and to increase that blood flow through your body, we can start to see this stuff accumulate, and we can also start to see other problems. We'll talk about that in respiratory. But yeah, so really bad diet and lack of exercise over time can accumulate this nasty plaque or straight up what? Bad genes, right? You guys, you hear about it all the time. I mean, not all the time, but you know, this dude was totally healthy, was 30 years old, had absolutely no medical problems, ran 3 miles a day, and then just dropped dead of a heart attack one morning, right? Guys, genetics, you can't run from genetics. If you just have a crap line of genetics from your mom or your dad or both, you are so much more predisposed to having these issues, even if you do have these, you know, a good diet and a good physical lifestyle. Genetics they suck sometimes, right? All right, what is the other one that doesn't have a picture? It's another A word. Huh? Arteriosclerosis. All right, because with this atherosclerosis, we have this plaque, it builds up, and it makes the diameter of my vessels more narrow, right? It clogs up that diameter and it makes it more narrow. How does arteriosclerosis work? So it gets kind of the muscular component, the muscular aspect in your vessels, they start to get kind of hard. They're not as flexible, they're not as pliable. And so they kind of stiffen up. It makes the diameter of the vessel smaller, and we lose that ability to kind of vasodilate. It doesn't really respond anymore. Guys, we typically see this over time, right? Just with age, day in and day out, all those years, we start to see the hardening of those vessels. Who else do we see this in a lot?
Older people?
So with age, yes. What medical condition do we see this a lot with? And it's the same kind of concept, but not really from the same etiology. Anybody? Diabetics who don't control their blood sugar. All right, now I'll come back to this analogy when we talk specifically about diabetes, but imagine a nice flexible silicone straw. Okay, you take that silicone straw that doesn't have any residue or anything like that, it's nice and clean and slick, and you put it in a super saturated, let's say, sweet tea, right? All those sugar crystals, all of that excess sugar starts to affect the properties or the structure of that silicone. It makes it hard and it makes it brittle, right? So if you're a bad diabetic and you've got way too much sugar floating around in your bloodstream, it's going to start to deteriorate the integrity of those vessels. So we can see that arteriosclerosis in diabetics who don't control their sugar. Okay. Everybody good on the two types of SVR? We're really going to be focusing on this one today. Okay. All right, so embolism, guys. Any embolism is a bad embolism. Right? Any emboli is bad emboli. That was one of the mottos when we went to paramedic school. We don't want anything floating around in our bloodstream, sticking in our bloodstream, accumulating in our bloodstream that's not supposed to be there. Okay, guys, this includes air and different gases. And it also includes, what do you think? What else can cause clot? We just talked about
Plaque.
plaque. Okay, and also what else? So that kind of contributes with the plaque. It starts to kind of stick together and snowball. Okay, so an injury, what can be secondary to an injury? What? I thought I heard somebody say it. If you have an injury, internal or external, you typically do what? Bleed blood. All right, so like coagulated blood can also cause an embolus. So anything that causes a structure, a clot that shouldn't be there is going to be an embolus. And then we start to define it as a thromboembolus when that clot breaks off from its natural habitat, right, wherever it is in the body, and it starts to freely float in our circulatory system. That's when we start to have big, big problems, is when we have a thromboembolus.
Why isn't it bad when it's just chilling?
I mean, it is, but if it's just chilling, it can cause localized problems, right? But if it breaks off and it becomes a thromboembolus, wherever it lands in that vascular system, we can start to see problems. We can cause a heart attack, a stroke, pulmonary embolus. So if you don't take care of a stationary clot, it will eventually become a thromboembolus. So no embolus is good embolus. All emboli, bad emboli.
So
If you don't take care of it, right? If you don't recognize, because there are these things called DVTs, deep vein thrombosis. And if they are stationary, and if you recognize that it's there, your doctor can typically put you on like a blood thinner or like compression socks or something like that, and it will eventually, I don't know, can't think of the right, in a safe manner, can kind of, degrade it and take care of it. But if you don't recognize that it's there and it's just chilling, it's a really big clot, and then that breaks off, then that's a problem.
No, I get that, I was just,
What causes them to break off usually? Is it just like it just happens eventually, or is it usually like you get into a car
Physical
accident
movement.
or something?
Physical movement.
so you know how if there's like
The machines where they inflate and they deflate. Yeah, so guys, we see these thromboemboli typically in the form of like the plaque or the blood. If somebody, let's say, like maybe during childbirth, this is not very, but it's common, especially if you have like a C-section, right? They give you medication, and what happens when they give you pain meds and all this anesthesia? What happens to your vital signs? You slow down, right? That blood pressure is not as high. It's not pumping as fast as it does. So if you're sitting sedentary for a long period of time, when we're suppressing that blood pressure, you can develop a clot, right? But then if you stand up and you start walking around after that clot's developed, and that physical activity increases your blood pressure, and it's forcing, more force through your vessels, it'll break off, and then it'll start wreaking havoc wherever it lands. So typically if somebody's been sedentary for a while, and then they're starting to get physical again, like moving and walking and all that stuff, that's when we start to see those, like, particularly blood clots.
How long is a while in this? Are we talking hours or days?
So typically it's gonna be days, but when surgery comes into play, all of the medications that you give has a drastic effect on the blood pressure and the vital signs. So somebody who, like my first knee surgery took like 5 or 6 hours, but they gave me blood thinners because I was going to be like stationary for 5 or 6 hours with that anesthesia medicine. So surgery, we're talking about hours, right? But anything else, which we'll really get to in the respiratory chapter, we're talking about days, weeks, type thing. Okay, sorry, I kind of went off on a tangent on that. All right, so guys, if we have a thromboembolus, right, that gets into our bloodstream, because guys, what happens to that embolus? Because they're not normally really, really big, right? But let's say we have, just obviously not true to size, an embolus that is this big, okay? If it breaks off and it starts going through my circulatory system, where is it gonna get stuck?
arterioles or
Or
capillaries.
Wherever in that circulatory system that artery or that vein, the diameter is smaller, hey Linwood, than the actual size of the clot, right? So if it happens to be in my coronary vessels, right, my coronary arteries, if that's where that embolus gets stuck, where it kind of gets wedged into,
you're gonna have a bad time.
that's a bad day. That's gonna cause an acute MI, all right, myocardial infarction. It's not fart. Some people like to giggle about infarction. All right, so if you see the term MI or AMI, it's a heart attack. Myocardial infarction, sometimes you might see that acute because it's happening right now. Okay, so we can have a thromboembolus that breaks off and finds its way wedged into my coronary arteries, or we can have that embolus that just occurs because of all that nasty plaque, right? I can just have that plaque accumulating in my coronary arteries, and then it just gets to the point where it gets too big and it occludes that blood flow. Okay. If I have any type of embolus, either it's secondary to that plaque or thromboembolus land in my coronary arteries, that is going to be what causes a heart attack. Okay. Everybody good with that? Just global definition?
Yeah, is that really common because that's like the first place that it gets really narrow after it like breaks off from veins?
Yes and no, because we can see an ischemic stroke, we can see a heart attack, and we can see a pulmonary embolus because of these thromboemboli they get. So it just depends on where it lands first. How unlucky and lucky you are. So yeah, it just depends on where it breaks off in the circulatory system and what the next stop is. Okay. So now we know what causes an MI, right? Let's talk about people who are more at risk for an MI. All right, so controllable risk factors. What does this mean? The patient can make the choice to say, hey, I don't need to do this, and I can eliminate that risk factor. I can control that decision, right? So what about cigarette smoking? Why does this matter? So it raises your heart rate. It also raises your what? Your blood pressure. Why? How? So it can cause some constriction, some vasoconstriction, but what's the bigger culprit? It is a mild form of a stimulant.
So the arteriosclerosis is the like stimulant.
It's not the arterio so much.
Oh, you don't get as much oxygen. So you don't get enough.
Okay, yeah, that's not wrong. Guys, if anyone's in here is a smoker, no judgment, but if you realize what is physically happening in your body because of these cigarettes, it's crazy. All right, there's a video we're going to watch for respiratory that will show you exactly what's going on. Guys, if you actually took a pack of cigarettes and look on the back and look at all those ingredients, and you looked up the ingredients, number one, I don't know how it's illegal that they can sell this stuff, but I mean, there's stuff like formaldehyde, tar residue, what's the other one? The other big one. The fiberglass, some type of derivative of something that's contained in like rat poison.
Yeah.
Okay. So not only does all of that nasty stuff start to accumulate inside of your lungs and in your bronchi and your alveoli, it will eventually kind of seep out and go start wreaking the same havoc on your vessels, on your vasculature system. Okay, so we have increased blood pressure. We have just nasty kind of grimy residue that ends up eventually in your vascular system as well. So yeah, cigarette smoking is a big one that can lead to a major risk factor to developing clots.
So it's arsenic, ammonia, acetone, butane, benzene, and acetic acid.
Yum, right? So again, I'm not judging anyone here who smokes. I'm just saying just the logistics of it, I'm going to talk about from a healthcare standpoint.
I actually interviewed Philip Morris. One of the engineering school. Smelled it.
No.
What year was that?
It was 1989.
Do they still have the smokers lounge at the airport?
They did.
Yeah.
I mean, it's like a concentrated.
Well, I think it's getting rid of theirs.
Yeah. A lot of places. I think
I already did. Because they had one for years.
last time I
Oh,
was
yeah.
there.
My parents smelled it. I like to make for it.
My mom had one in
All right, so guys, if you have that high blood pressure, whether you smoke cigarettes or not, But if you have a history of hypertension, you're more likely to develop a clot because of those two different factors we just talked about, okay? High cholesterol, what is this?
It's like the place to stick to and cause a clot.
Yeah, more nasty sticky stuff, okay? So if you have already high levels of that sticky ooey stuff floating around in your bloodstream, it's more likely to have that snowball effect. Those platelets will go by that sticky stuff and be like, oh, hey, I'm gonna stick to you. And it accumulates and accumulates and accumulates and a clot forms, okay? So guys, we already kind of touched on this, right? If you have a high blood sugar constantly in your bloodstream, if you're a diabetic who doesn't control your sugar, we start to see that arteriosclerosis, right? The hardening, narrowing of the vessels because of that sugar content. And lack of exercise and obesity, okay? Because we're not having that blood flowing through those vessels like we normally would if you're physically active or if you had less surface area to supply blood to, you're at a higher risk for creating a clot or creating a possible MI. All right, what can't we control that puts you at risk for an MI?
Genetics, being old.
Genetics is a major one, right? Like I said, you could run 5 miles a day. You could eat nothing but keto-friendly foods or, kale all day long. All right, it could be super, super healthy. You have those healthy habits. But if every single male in your family, even including your immediate biological father, has had a history of heart disease or a heart attack, bro, you're like 75% likely to follow the same fate. Okay. So again, age, we see that arteriosclerosis the older we get just because of that time. This plays into genetics, all right? Certain races, certain ethnicities, certain sexes. Like being a male, you're more predisposed to have a heart attack because you're a male.
Why is that? That last one.
Hormones have a good play into it. That's why males typically don't live as long as females. Sorry, guys. All right, if you are a black male, your chances go through the roof again. All right, so just all of that genetics that come into play make different sexes and races more susceptible to these things. You can't run away from genetics, good or bad. All right, so guys, you're gonna see this term ACS, acute coronary syndrome. Okay, we particularly refer to this when we talk about angina pectoris and these AMIs, these MIs that we're talking about. Okay, what do you think angina pectoris? Again, get the giggles out. It's not vagina. It is angina pectoris. Chest pain. All right, so angina is going to mean pain, and pectoris refers to the chest. So angina pectoris is chest pain. All right. Now we can have two different types of angina that you need to be very aware about. Okay. We see this angina pectoris because what's happening. Typically, if you're experiencing chest pain and it is related to a cardiac event, right? It's not like a muscle spasm because it's been a really long time since you went to the gym and did some cardio, right? If it is related from a cardiac event, if it has what we call a cardiac etiology or origin, why do we experience that chest pain? What is that?
The heart is overworking.
Heart's overworking. It's because of the lack of oxygen, guys. When we're having a cardiac event, if you have that chest pain, it is a distress signal from the cardiac cells saying, hey, 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 we don't have enough oxygen, and if you don't fix it, if you don't give me the oxygen that I need, I'm going to die.
And then you're going to die.
And then you're going to die. All right, so that if you have a patient who experiences chest pain during a cardiac event, it is that distress signal being sent out by those cardiac cells saying, I am hypoxic. I am experiencing a state of ischemia. Fix it, please. All right, because guys, what's true about cardiac cells in death? We don't regenerate them. Right? If you cut yourself, again, you don't bleed out, you form a scab, we form new skin. We regenerate skin cells. Not true for cardiac cells. Once they die, They don't come back, and they sit there on the heart just like scar tissue, just like a bump on a log. They don't help contribute to contractions. They don't help contribute to the electrical conduction. They just sit there like dead weight.
Will they ever like trim some of that off? Somebody have to do it.
Okay. So with this angina pectoris, we typically, guys, I need to put a big blanket statement on when we start talking about heart attacks. There has been maybe one textbook appearance of a heart attack that I've ran out in the field. Heart attacks are sneaky mother lovers. All right. It's not very likely that you're going to see the left side of my chest hurts. Oh, my left arm goes numb. That's what they portray in the movies and what they portray in TV, but that is just one of the several ways a heart attack can present itself. Okay. So typically, if we have that chest pain during a cardiac event, we're going to get more of a crushing sensation, like a pressure. All right, so that's why it's important when we talk about the OPQRST acronym. Okay, what does OPQRST stand for? Onset, provocation or palliation, Q, quality, R, radiation/region, S, severity, and time, right? Because when we get to that quality, that's where we want to hear an adjective. What kind of pain is it? Right? And if the patient says, oh, it feels like somebody's just sitting on my chest, or it feels like somebody's just squeezing or crushing my chest, then we're going to say, okay, let's start to go down maybe it's a heart attack route, or maybe it's a cardiac event route. It doesn't mean that it could be another adjective for somebody else, right? But typically we see more often than not that crushing or pressure sensation when it comes to the pain for a heart attack. All right. We have two types of angina. We have stable and we have unstable. So stable angina and unstable angina. What do you think stable angina is? So maybe a bearable pain. All right, guys, in some way, shape, or form, we are experiencing a mild version of ischemia to these heart cells to create this angina pectoris, to create that chest pain.
Would stable angina just be something that we can stabilize in the field?
Yes, in theory. Okay, so with this stable angina, they might be having just some temporary vasospasms that are causing that temporary state of mild hypoxia or ischemia. All right, why is it labeled stable? Okay, it can be shooting pain. Okay. Guys, typically we'll say, okay, you just had a run or a case of stable angina. If the patient, typically this is brought on by physical activity, right? Going out and cutting the grass, going to the gym, moving boxes, sexual intercourse is a big one where we see this present, especially in older males. Okay, but that strenuous activity, that physical activity, typically brings on some of that chest pain. If that patient is able to, let's say they're cutting the grass and they start to get that chest pain and they say, all right, I'm going to take a break. I'm going to go sit inside. I'm going to cool off and I'm going to stop doing that physical activity. If the patient goes and rests and that pain subsides, it goes away, we consider that stable angina. Also, if a patient does what else and the pain resolves, it's considered stable angina. Go back and think about pharmacology with this one. Medicates with what? Nitroglycerin. Right? These patients have had to have been diagnosed with stable angina to have a prescription for nitro. These are the patients you're going to come across who have their own prescription of nitro. They have a history of stable angina. All right, so you know right off the bat, if they have that prescription of nitro, they have cardiac history. Okay, so if this patient is having this during this physical activity, and they start having that chest pain, they go and sit, they chill out, they rest, or they take their nitro, and the pain subsides, stable angina. Where do you think we move into unstable angina?
When it doesn't.
It doesn't go away. Right? They can stop cutting the grass and go sit inside and cool off. They can take their nitro, but that chest pain is still there. Because guys, think about it. If you're having these episodes of vasospasms and these states of ischemia to your heart, what are you going to be more susceptible to? A full-blown heart attack. Right? So if that pain is not resolving with that rest, it's not resolving with that nitro, it could be that we have now progressed from that stable angina to we're actually experiencing a heart attack now. Okay. Guys, even with the patients who have that stable angina, we're still going to go down that chest pain protocol, right? What drugs do you think we're going to give? So we're going to assist the patient with their nitro. What's your dose of nitro? What? You're definitely going to kill your patient.
4
All right,
tablets.
what's your dose of nitro? So they come in
1.2 milligrams.
form, spray, and each dose is
0.3 or 0.4
0.3 to 0.4 what?
milligrams.
All right, what's your max dose of nitro?
1.2.
1.2 milligrams. Right? So if you do have a patient who has a history of stable angina, and they said, yeah, I did what the doctor told me to, I started having chest pain, and I took 1 nitro before you guys got here, how many more can you give him? 2. Right? That max dose, whether the patient does it themselves or whether you do it, is 1.2. What's a contraindication for nitro?
Any other nitro-based medication?
Okay, other nitrate-based medications such as?
Viagra.
All right, Viagra, Cialis. What else?
Some blood pressure medications.
There are some blood pressure medications that are nitrate-based. If they've had any of those over the past 24 hours, can't give it to you. Why? Why is that a contraindication? What is the proper
Cause your blood pressure to go too low.
Okay, what'd you say on Zoom?
I was saying you could bottom out your blood pressure.
Why? How?
Because
the mechanism of action for nitro is it causes vasodilation. Why do we want to cause vasodilation in somebody who's experiencing chest pain? What did we say chest pain is? It's a distress signal because these cardiac cells are experiencing hypoxia.
Right.
Right? So we're going to give the vasodilator to do what?
That open up that blood vessel.
Open up those floodgates and get as much blood as we can to those cardiac cells and in turn get as much O2 molecules as we can to those cardiac cells. Okay, so no nitrate-based drugs within the past 24 hours. Guys, if they just took their home or their own prescription of nitro 10 minutes ago, that's fine. But anything else that has a lingering effect in the body, I'm worried about, right? What's another big contraindication for nitro?
Low blood pressure.
All right, so what's your magic number for your blood pressure? At least 100 systolic. Because again, guys, that vasodilation property can cause your global blood pressure to drop. Usually not significantly, but it can cause a significant, you can bottom out your patient's pressure. How often do we wait in between? 5 minutes, guys, not 3 minutes and round up. 5 minutes. That's how long it takes for that drug to get in your system and have the effects with that vasodilation so we can see how sensitive your body reacted or how not sensitive your body reacted to that nitro. What else are we doing in between each dose?
Vitals again.
So we're going to get a blood pressure, absolutely, but we're also doing what? Why are we giving it?
asking about the plan.
We're giving it in hopes to resolve that hypoxia, that ischemia to the heart cells, which is causing that pain, right? So if your patient starts out with 10 out of 10 chest pain, every other box is checked, they're a candidate for nitro, and I give them 1 tablet of nitro. 5 minutes later, if their blood pressure is still good, I'm gonna say, hey, what's your pain scale? If they tell me, oh, it's an 8 or it's a 7, if it's trending downward, what does it mean? It's working. That chest pain's getting less and less severe because I'm providing more and more oxygen to the cardiac cells, right? So that's why if all of those other check marks are in place, we're not going over that 1.2 milligram dose, that blood pressure stays sufficient, all right, I'm gonna give nitro until my patient says there is a 0 pain level. If they're not having any chest pain, then I know those cardiac cells are no longer in that state of ischemia or hypoxia. I fixed the problem. A good little recap of nitro, why we use it for chest pain. Okay. What other drug do we use for chest pain? Aspirin. Right? Because remember, why do we use aspirin? What does it do? So it's an anticoagulant based on, what does it do to the platelets? It's a platelet aggregator inhibitor. Right? Because let's say we've got this atherosclerosis. There's my artery. Here's my wee little piece of plaque. It's gotten nice and big now. It's starting to wreak havoc. All right, if I have some colors up here, my blood flow is going to continue to go through this artery as long as it's got some kind of pathway, right? What's included in my blood?
Platelets.
Platelets. Platelets are sticky. So the more that my blood is flowing, my platelets are going to be passing by this already sticky, gooey plaque. All right, and the platelets, when it comes in contact with them, it's going to be like, oh, hey, we have the same properties. We're sticky. Let me stick to you. Oh, hey, let me stick to you. Let me stick to you. Until eventually all of these platelets cause that snowball effect. And now that big, sticky, ooey, nasty plaque clot is totally obstructing the blood flow to my coronary artery. Okay. So guys, aspirin is not technically a blood thinner, right? But it just makes those platelets slippery. So when it bypasses, those platelets go by that already existing clot, they're just going to kind of glide right off of it. We give the aspirin in hopes to not make that clot bigger and bigger and bigger. We're not going to take it away. It's not going to dissolve it and get rid of it altogether. But we don't want it to get bigger, and hopefully we can have some type of blood flow and it doesn't become a total obstructive clot. And then what else if the patient needs it? Oxygen, right? We want to super saturate those red blood cells that we're opening up the floodgates with nitro. So all of those O2 molecules can get to those cardiac cells. That's your chest pain cocktail, right? At the paramedic level, you might see what added? Morphine or fentanyl for pain management. But that controlled substance is not within your scope of practice yet. Okay, is everybody okay-ish? Stable angina. If it's not resolved, it leads into unstable angina, which is pretty much we're having a heart attack, right? Okay. Guys, again, once we lose cardiac cells, we don't get them back. They don't regenerate. A clot busting drug can be given once you get to the hospital. They're going to do their own 12 lead. They're going to do all these tests. They're going to draw blood. Because again, guys, that's not a luxury we have in the back of the truck. They can draw blood at the hospital, send it off to the lab, and if different levels or different markers in the patient's blood are elevated, that's a sign of stress that says, yes, we are having a cardiac event because these, typically like troponin, is a level that becomes elevated during a heart attack. Just a byproduct of that stress from the heart, okay? Or what they do is they can take them to the cath lab, okay? This is a really cool place. You might get lucky enough to go up there with your patient one day. but any facility that is a STEMI facility, we'll talk about what that means in just a second, all right, has to have a 24-hour cath lab, which means the patient can go, they can confirm that the heart attack is being, is present. They take them to the cath lab and they access typically their femoral artery, and they go in with like a cool little tool, and it's kind of like a roto-rooter, like with a drain cleaner, right? It just kind of like goes through the vasculature, and they can actually like grab onto that clot and extract the clot.
That is cool.
It's crazy. Or they can kind of dissolve it, but typically if they're going to the cath lab, it's big enough that they can actually take it out. Okay. There's the same procedure when it comes to a stroke, except with extracting it from the heart, they're taking it out of the brain vasculature. I think they go through some plate for that. Okay. Crazy cool. Typically the femoral or the subclavian is the most popular access for cath lab. So again, guys, is a heart attack patient a time-sensitive patient?
Yes.
Yes. All right. We there's in EMS there's a door to balloon time, right, or a call to balloon time, which means by the time we arrive on scene, we pick that patient up, we activate that stimulate, we take them to that facility that has a cath lab, and they get taken up to the cath lab, and they've got that balloon in their vasculature getting that clot out. 60 minutes. Ideally, in an ideal world, right? We don't have traffic.
What did you say it was called? What is it called?
Typically, you hear it referred to as like a door to balloon or a call to balloon time. But as we want to keep that golden hour rule with these STEMI patients absolutely in mind. Okay, if we have any suspicion that we're having a cardiac event on scene, that's a load and go mentality. 10 minutes or less, let's load them up. Let's transmit that 12 lead EKG. Let's call a STEMI alert. Depending on who the doctor who takes your report, they might say, hey, don't even bother going through the ER, go straight up to the cath lab. We'll meet you up there. Okay. Again, guys, you can't do much. I mean, you can do a pretty good bit for heart attacks in your scope. You can give nitro if the patient has it. You can give aspirin, you can give oxygen, and you can obtain a 12 lead. You can send that 12 lead off to be interpreted by a doctor. You can't interpret it, but you can absolutely activate a stimulate and have confirmation by that doctor looking at that 12 lead that you sent over. Yeah, big heart attack. Okay, you've got to be able to recognize these things, right? If you're just saying, oh, this patient's fine, they're a 70-year-old female, they're having abdominal pain, there's no way it could be a heart attack. She's not having chest pain. You're going to kill a patient if you get those blinders on. So it's very, very, very important that within your scope, you recognize these time-sensitive cases are going on, and we do the appropriate activations and all that jazz. Okay. Okay. Signs and symptoms. Guys, notice it is not just chest pain and left arm numbness. That's what you're going to see in the movies, right? You always, I think even in the freaking AHA video, right? Dude in the airport, he was like, oh, can't breathe. And then Sam in the bathroom, he's like, and they collapse. It's not always going to be like that. Okay, so that is one sign and symptom of a heart attack or an MI, that you do have that chest pain. Okay, typically if we hear the adjective when we're asking for the quality, if it's that crushing or that pressure, that's like, okay, we might be having a cardiac event. Okay. What do I want to know when it comes to region radiation? What might make me concerned?
It's like radiating.
So I want to know that region. What does that mean? Guys, did we go over OPQRST?
No.
Not really. I know.
Everybody's give a sample, right?
Yes.
Okay, so really quickly, OPQRST is another acronym that we're going to have for particularly medical patients. Right? That's going to say, tell me more about this pain. Why don't we really use this for trauma patients?
Because it's a traumatic injury. You know why they hurt, probably.
Okay, if your left ankle bone is sticking out of your ankle, do I have to say, well, can you tell me exactly where it hurts? Does it move anywhere else? Is it a sharp pain? How long ago did it happen? I don't care. That's why I know that's why you're hurting. Your ankle bone is sticking out, right? But we use this OPQRST acronym because a lot of medical problems, particularly this heart attack, can be very sneaky in its presentation. All right. So what is O when it comes to this acronym? Onset. There's only two things I want to know. Was it blank or was it blank?
Quick.
Sudden or not sudden?
Sudden or gradual? Right? Did this chest pain just hit you like a ton of bricks out of nowhere? You're sitting on the TV watching Wheel of Fortune and bam, just hit you? Or has this been getting worse over a period of time, right? Has this been getting worse over a couple of hours and now it's just to the point where you can't stand it, so you call 911? I want to know if it was gradual or sudden. Because guys, spoiler alert,
Sudden is bad?
sudden's bad. You're not going to have a heart attack over the course of a couple hours, right? You're going to be dead by then or significantly impaired by then, right? So I want to know if it was gradual or if it was sudden. Okay, what is P? Provocation or retaliation. Provocation means what? Is there anything that you do that makes the pain worse? Right? So especially with these stable anginas, if getting up and moving around, does that make the pain worse? All right, what's palliation? Yeah. Is there anything that you can do to make the pain better? Right? So for those stable anginas, if you sit down and you rest, you just chill out, does that make it better? All right, so is there anything that you do that makes it better or worse? Q? Quality. This is where I want to hear what? An adjective. Describe the pain to me. Now guys, you're probably going to have to give a word bank to your patients when it comes to this. Because people who have no medical knowledge whatsoever, if you come into them and be like, can you describe the pain? Like, it hurts. I don't know. It's pain. All right, so this is where it comes, well, is it a crushing pain? Is it like a stabbing pain? Is it a burning sensation? Is it, very, very intense, or is it a dull throbbing sensation? All right, so we're gonna give kind of a word bank. And typically once we start giving them options, they'll be like, oh yeah, it's crushing. It just feels like somebody's sitting on my chest. R. So region/radiation. With one finger, can you point to exactly where it hurts? Okay, they either can or can't. They'll either say, yeah, it hurts right here, or it just hurts like this whole area. Okay, now if they can pinpoint that particular region, does it go anywhere else? Does it radiate anywhere else? Does it go down your left arm? Does it go around to your shoulder? Does it go up to your jaw? So region and radiation, I want to know if they can pinpoint it, and if they can, does it spread elsewhere? S, severity, what I want here. On a scale of 0 to 10, guys, y'all can get creative with this. All right, 10 is being attacked by a swarm of bees while being mauled by a grizzly bear at the same time. Right? The worst experience you can imagine or have experienced in your life, the worst pain, and 0 is nothing at all. Guys, what do we have to remember here? Pain is
Relative.
subjective. Pain is relative. You got to remember, people can either be super dramatic, they can be very tolerant to pain, they can be very intolerant to pain. Okay, so you chart exactly what your patient says, whether or not you believe them. That doesn't go in your chart because that's an opinion, right? But you have to treat based on that patient's pain level per protocol. Even if I don't believe for a second this person's having 10 out of 10 pain, chest pain. But they're saying these things, they're saying it's 10 out of 10, it hurts here, it hurts there. If I have that charted in my documentation and I didn't do anything to treat for chest pain, I didn't rule anything else out, QA's gonna be all over me. Why didn't you treat for chest pain? Well, they were, talking on the phone the whole time and drinking, a Sprite and just acting totally, they were joking around. They were trying to talk to me about, Elvis and all this stuff. It doesn't matter. Maybe they had a very high pain tolerance. 10 out of 10 pain, you didn't treat for chest pain. You didn't give them drugs. Okay. Severity and time. What do I want to know here? How long has this been going on? Has it been going on for 10 minutes? Has it been going on for 10 hours? Okay, I want to know how long since you started to experience this chest pain to when you called me, what that time frame was. Okay. Everybody good with OPQRST? Everybody see now why we don't really use this for trauma patients? It's more so for medical. Samples for everybody. But OPQRST is more so medical because it could be a bunch of different things.
What's the P?
Provocation or palliation. There we go. All right, so again, guys, we have that chest pain, that discomfort, that pressure. All right, so the arm pain, guys, this is a big one. Weakness, nausea, vomiting. Okay, there's going to be three that I talk about today. The biggest heart attacks that I've ran in my entire career. One of them was like an 84-year-old female, and her only complaint was vomiting. That was it. She was pale, cool, clammy, and she was puking. And her daughter even said, we just ate lunch like 30 minutes ago. She might have had something bad to eat, but she was having a massive heart attack. Okay, so nausea, vomiting, that sweatiness, okay, that's a big kind of red hair, kind of gets you distracted that, oh, it's something gastro, right? They ate something bad. There's no way this could be a heart attack.
So how did you find out?
So guys, that's going to be part of your education and knowledge, particularly in females above the age of 45. They can present totally atypical when it comes to MIs. So it's actually Grady protocol that if we have a patient above the age of 45, if they have X amount of complaints, they get a 12 lead. It might be that she ate some bad potato salad and she's puking her guts up, but I have to take that 12 lead to rule out the fact that it could be a heart attack. So you very, very, very much need to remember females across the board, particularly over the age of 45, present atypically when it comes to MIs. So if you've got a 50-year-old female saying, I don't know, man, my stomach doesn't feel right, I don't know, I don't feel good, you better get a 12 lead. Because it could be an MI that you're missing. Geriatrics, guys, across the board, male or female, typically don't present with that textbook chest pain. Okay, again, their pain receptors are wired differently, right? They're kind of degrading. They might present with something totally off the scale, off your radar. Geriatrics, and in particular females over the age of 45, are atypical most times. Don't forget that. You can always get a 12 lead to rule it out. We're going to come back to that term differential diagnosis in just a minute after we finish talking about this. Okay. Irregular heartbeat and syncope. Okay, we could be having those dysrhythmias that are not allowing proper perfusion because we're having a heart attack. Again, nausea, vomiting, sudden death. Yeah, that would be, could be because of an MI, right? This pink frothy sputum, guys, this is particularly when it comes to CHF, right? A particular type of CHF. If we see this presenting, it could be a cardiac issue. Jaw, arm, back, abdomen, or neck pain. The other two massive major heart attacks I've ran One was, I think she was like 50-something-year-old female, and she called because her jaw hurt. She just felt like, you know, like she had just like some muscle pain, and she was like, I don't know, it just feels weird. I've never felt this before in my life. That was her only complaint. Around 12 lead, she was having a massive heart attack. Other one was a 32, I believe, year old male, big guy. Like you could tell he went to the gym, he was healthy. He said, you know, I just got back from the gym like 20 minutes ago. It felt like I maybe like pulled a muscle right here in my shoulder. I put icy hot on it. I went and I sit in the hot shower just to see if it was like a muscle to kind of work itself out. And it just, I've never had this feeling before, so I figured I'd get checked out. I'm on 12 lead. Massive heart attack. Okay, so guys, heart attacks can be sneaky. Don't forget, it's not always just going to be that chest pain. My left arm's tingling, it feels numb. Okay, that jaw pain, shoulder pain, nausea, vomiting, dizziness. All right, so geriatrics and females, particularly above the age of 45, don't usually present the typical signs and symptoms of heart attack. Okay, everybody clear on that? Hi guys, so again, if we're having this major pump problem, right, my heart's having ischemia, it's not pumping effectively, how do you think that's gonna affect my vital signs? Typically, usually, negatively, right? My cardiac output's not gonna be as good, so my blood pressure's not gonna be as good, my heart rate's my heart's stressing out, so my heart rate's probably gonna be elevated. We're probably gonna see maybe those signs of like compensated shock, right? Respiratory rate's probably going to go up. Patients express feelings of impending doom. What does that mean? Because it is a sixth sense that they get. All right. If I'm not talking about, guys, if you have that grown man who stubs his pinky toe in the coffee, he goes, oh my God, I'm gonna die. It hurts so bad. Bro, no, you're good. You're good. Okay. But if you have that patient who you're like, I don't know, maybe it's that, okay, well, my stomach doesn't feel right, or my jaw hurts, or my shoulder hurts, and you just can't pinpoint, but that patient is just kind of have just like that, can't get comfortable, and they start to tell you something's wrong, or I'm going to die, and you can't 100% figure out what exactly is going on with your patient. Listen to them. I will tell you my F-up story in the respiratory chapter next when it comes to that. It's a sixth sense they get. If they tell you they're going to die and it's a legit, it's not just a stump toe and they're being dramatic. Okay, let's get a 12 lead just in case. Let's do this just in case. Okay, so that impending doom is a real thing. All right. Sudden death. Guys, if you have a massive heart attack, your heart is deprived of oxygen and it can't pump appropriately. Can it cause cardiac arrest?
Yes.
Yes. All right. Cardiogenic shock. Again, we have a pump problem, right? My heart's not getting that oxygen. It's not pumping appropriately. It's not going to have sufficient output. That blood pressure is not going to be there. That perfusion is not going to be there. We can go into a state of hypoperfusion because we have a major pump problem. Is that fair? Okay. Congestive heart failure. Guys, what is this? What is CHF? It's not really clots. You can develop CHF secondary to an MI, right? Because we talked about if we have the death of that cardiac cell, what does it do? If it straight up dies, it doesn't come back. It just sits there like a bump on a log, like scar tissue, right? It's dead weight. It's not contributing to effective pumping, effective contractions, effective perfusion, all right? So the rest of your heart is going to have to make up for this little dead space over here, right? And sometimes it can't make up for it. Sometimes it can't compensate, or sometimes it can only do it for so long. So we start to see CHF or congestive heart failure where just through maybe secondary to a heart attack or uncontrolled high blood pressure, the heart just cannot perform its job anymore. We'll get into that a little bit more detail in a minute. But understand you can develop congestive heart failure secondary to an MI if we have a massive amount of scar tissue or that dead cardiac cell. Okay. Guys, we kind of touched on these for CPR. What's a PVC? Premature ventricular contraction.
Exactly what it sounds like. The ventricle fires before it's full.
Okay. So the ventricle says, it's really excited to contract, and it says, hey, I'm going to see, you're going to see a contraction before it's supposed to, right? Before all those chambers are filled. When we see what we call these PVCs, that's typically if somebody's saying that they're feeling their heart skip a beat or they're having palpitations, they're throwing a bunch of PVCs. Something's usually off a little bit. Maybe that electrical is misfiring, that ventricle is getting that stimulus before it should. But PVCs in moderation are not bad. We can usually self-resolve these PVCs if we give the patient a little bit of oxygen. They usually go away. But if you get to a run where your ventricles are firing rapidly and prematurely a lot, not conducive for perfusion, right? Tachycardia, was that fast? Because it can get up to like 200s fast. All right, if it is pumping that fast, do you think it's having enough time to relax and refill? No. Even if everything's going the same way, right? Even if the conduction system's on point, there's no electrical abnormalities. If it's pumping that fast, it's not having time to relax. We're not going to have anything to pump out, and we're not going to be able to perfuse with a heart rate that high for that long. Same thing with bradycardia. What was that? Too slow. Okay, there's not enough force, right? Because if that heart is only beating like 30 times a minute, okay, it's only pumping out that blood so often, it's not going to be enough force, enough pressure to provide perfusion. VTAC, what was that? Talk about that in CPR.
Specifically the ventricle.
Ventricles are going nuts, right? The ventricles are just pumping. They're not including the atria. We're not including that refill and relax. We're eventually going to run out of blood to pump to the body, and that's not going to lead to perfusion, right? VFib.
Ventricle is not even squeezing it out.
Right? It's just the heart's just kind of sitting here doing this. There's no contractions, there's no pumping, there's no perfusion. Are you going to ever have a pulse if the patient is in VFib? No. Is it possible to have a pulse with VTAC?
Yes.
Yeah.
For a little while.
For a little bit. You can have a pulseless VTAC or a VTAC with a pulse. But yeah, they won't have a pulse for an extended period of time if they're in that VTAC with a pulse. All right, so guys, we talked about that early defibrillation, getting that AED on your cardiac arrest patient as soon as possible. What is asystole? Bad. What is not present at all? Any electrical stimulus, right? That's why we don't shock asystole, right? Why does the AED pick up on that VTAC and that VFib and say, ooh, hey, I can shock you? There's some type of electrical stimulus. That AED is going to go up to the heart, slap it in the face, and say, hey, get your crap together, right? But if my heart's unconscious, unresponsive, laying on the floor, there's no point of me going up and slapping an unconscious, unresponsive person and saying, get your crap together. I can do it, but it's pointless, right? Nothing's going to happen from it. So I believe this is during a surgery. Yeah. All right, so see how this is kind of quivering? Hold on. Get this bar. All right, so look down here. That's what the cardiac monitor is going to show. Is that normal?
No.
No. So this actually looks like what we call polymorphic tachycardia. So that is something that we can, it doesn't look like an organized chaos, right? So remember that VTAC, everything looked nice and uniform. This has got some inverted waves. It doesn't really look nice and neat. So this is how the heart's going to present. All right, so this is kind of quick, right? But just watch how it's kind of not having an organized motion while this abnormal rhythm is showing up. All right, they just delivered a shock with this instrument and this instrument. So notice when they delivered a shock, what happened to that rhythm? Okay, it went into a temporary asystole. That's that moment where you're slapping that person freaking out of the heart in the face, and they're having that, oh, moment of realization that I need to get back to normal. And then so after that happens, that was a normal contraction. Now we see that normal squiggly line on the cardiac monitor. Okay, so I'll watch it one more time.
Turn it off and turn it back on.
Not appropriate, not appropriate. This is what we're seeing on the cardiac monitor. There's no perfusion here. Shock. Okay, let's get back to normal. Okay, so that's what your AED is doing externally from your patient. It's obviously not open heart surgery. You're not directly touching the heart with the little paddles and shocking it, but that's why the AED is so important to get on there very quickly. Make sure if we're in shockable rhythm, that's what it does to the heart to try to get it back to normal. Okay? Okay. Everybody good on cardiogenic shock? What's not happening here?
Right now.
Perfusion, secondary to what?
Kind of heart failure or
What kind of problem?
pump problem.
Pump problem. Right? Again, if I'm having a heart attack, those cardiac cells, that muscle dies. It's not going to contribute to anything that the heart normally does. The heart can only compensate for so long. We're having a pump problem. We're not perfusing. All that jazz. Everybody good with that? Okay. All right. Guys, so congestive heart failure, I'm pretty sure we talked about this a little bit later. So we'll come back to that. Hypertensive emergencies. All right, so we're talking about vital signs. If I have an elevated blood pressure, if I have a patient who is hypertensive and I take a step back, I'm going to look at my patient and be like, you know, do you have a headache? Or do you feel dizzy? Do you feel this and this and this? If they're like, no, I normally have high blood pressure, am I going to be super concerned about that blood pressure? Not really. That's probably normal for my patient, right? But if I have a patient who has that, somebody said they got like 170, 180 systolic?
Yeah.
Okay. And that patient is having signs and symptoms, right? Really big signs and symptoms that your blood pressure is way too high and your body's freaking the F out. Okay. A lot of common ones are going to be ringing in the ears. You guys know what I'm talking about, right? Like if you're just, sometimes you can just be randomly sitting and it's like, sounds like just like that almost tunnel sound in your ear. So that ringing in the ear sound. Headaches, okay, visual disturbances. What does that mean?
Like auras and stuff like that?
Not aura. Like sometimes you see like little floaters or sometimes your vision becomes a little blurry, okay. Another big one is going to be nosebleeds. Okay, nausea, vomiting is also up there. But nosebleeds are common. Why?
Capillary just bursting too much pressure.
Yeah, guys, those itty bitty, tiny, teeny, microscopic capillary beds are only, structured to withstand so much pressure, a normal blood pressure. If you've got a crazy like 180, 200 systolic pressure pushing through those capillary beds, they're going to burst, literally like burst open. And so we see the blood from the burst capillary beds, usually in the nose, hopefully in the nose, because where else can that happen? Brain. That's not good. I ran a guy up in Buckhead. He was at, I think it was like the St. Regis, just like swanky hotel. in Buckhead. He was there for a conference. He was a presenter, and he was on the podium and just was in mid-speech and just started pouring blood from his nose. All right, we get him in the back of the truck. He was like, he didn't want to be evaluated, but we convinced him. His pressure was like 210, systolic. What was the only thing he cared about?
His presentation or
His suit,
or, yeah.
his $4,000 suit. And I'm like, A, you're an effing idiot for spending $4,000 on a suit.
Cut it off.
Huh?
No.
I mean, it wasn't, yeah, it's not would have ruined it any more than the blood, I'm sure it did.
Peroxide. Peroxide does wonders to blood and clothing. But yeah, he was just concerned. He was like, no, I got to get back up here and finish this and that. And he was pissed about a suit that had blood all over it. And I'm like, bro, you probably need a new career because your blood pressure is way too high. Because guys, if you have a significantly high blood pressure, you hear all the time, man, you're gonna stroke out. Okay, so same concept of bursting those capillary beds that cause the nosebleed from that immensely high blood pressure. You can do the same thing to the vasculature in your brain. You can burst, you can rupture the vasculature in your brain, and you can have a stroke if your pressure is significantly through the roof. Like, man, your pressure's high, you're about to stroke out, you need to calm down. Okay, so those are some very common, if we're having those signs and symptoms on top of a high blood pressure, this is a concern because we know what bigger problems could eventually come from that high blood pressure, stroke territory. Okay. So again, stroke, dissecting aortic aneurysm. Okay. Aortic aneurysm. All right, guys, what is an aneurysm?
Isn't it a bursting of like a blood vessel, like suddenly?
All right, so everybody, there's always a misconception as the definition of an aneurysm, just like heart attack and cardiac arrest. A lot of people don't realize it's not the same thing. Okay, so when it comes to an aneurysm, again, here's a healthy artery. I'm going to draw 3. All right, we typically see these arteries, aside from really, really bad genetics, like just a crazy medical phenomenon, okay? We typically see these aneurysms develop because of high blood pressure. All right, so these are going to be your arterial walls. Guys, are arteries designed to withhold or to sustain pressure? Do they work under pressure? Yes, right? But a normal range of pressure. If I have a ridiculously high pressure pushing through my arteries, at some point they reach a breaking point. Okay, so if they're consistently day in and day out under immense high pressure, the wall of my artery is going to kind of succumb, be compromised from that immense pressure. It doesn't initially burst, right? But if I have just kind of all of the pressure is pushing up against the arterial wall and it kind of juts out like that, that's an aneurysm. Okay? Just imagine, I have a 3-year-old, so this is the first thing that comes to mind. Those stupid squishy balls that have like the net around them, and if you squeeze them, like all of the gel stuff just kind of like pokes through the net, kind of path of least resistance type thing. But that only happens when you're squeezing the crap out of the ball, right? It doesn't break. The gel doesn't, go everywhere. It stays contained, but we have a structural compromise in the wall of the artery because of that high pressure. That's what an aneurysm is. That's when an aneurysm develops, is when we just have that kind of balloon out. All right, we can have a dissecting aneurysm, which is kind of the second stage. We still kind of have that little balloon, but the inner walls, the inner linings of the artery, they're still under that immense pressure. They're kind of starting to separate from each other. Again, this dissecting aneurysm has not yet done. ruptured. All right, so we can have an aneurysm present, and it's not good that it's there, but if we catch it, we can treat it, we can fix this, right? My wall has been compromised, but it hasn't been opened yet. That blood circulating in my arteries is still contained. All right, we move to the dissecting when that pressure is still there and those inner linings, and remember there's about like 4 different inner linings of the walls of the artery, they start to kind of pull apart from each other. At this point, still everything is still contained. We haven't poked a hole through the wall of the artery. That happens when we have a ruptured aneurysm. That blood is no longer contained in that vessel wall, that arterial wall, and now what's happening here?
You bleed out internally?
You're bleeding out internally.
Are these like ever survivable, or if it gets to this point, you're just done?
Not usually. Okay, so guys, these can happen in the brain, and we'll talk about that when we get to the neurological emergencies. Or another very common area that they happen is in that descending aorta. Okay, you're gonna hear this referred to as a
Abdominal aortic aneurysm?
AAA, not the roadside service. Okay, abdominal aortic aneurysm. By the time we get the call, typically the call that we get is when it's to the point where it's ruptured. All right, so they had a pre-existing aneurysm there, they just didn't know about it. When we get these calls for these signs and symptoms, it typically is to the point of rupturing. Okay, so with a AAA, typically this is going to be a patient who has significantly high blood pressure that doesn't control it for one reason or another. Maybe they don't take their meds. Maybe they refuse to change their diet or physical lifestyle. Maybe they just have really bad genetics and everything they do just doesn't work or doesn't help, right? But when it gets to the point of rupture, there is a very specific presentation when it comes to these AAAs. Okay, anybody know how these might present? A tearing sensation in between the shoulder blades.
Followed rapidly by hemorrhagic shock.
It's followed rapidly by death. All right, so guys, we're getting to what's called referred pain, right? Is your descending aorta right up here in your shoulder blades? Okay, it's right here. The abdominal aorta descending to abdominal aorta is here. All right, but just the nerve bundles that it lies on or around, the pressure that's released when it ruptures, we typically have a tearing sensation in between the shoulder blades. Okay, it is possible that if it's a smaller aneurysm that has ruptured, we might have time. We can get them to the OR, they can fix it. But if it's something massive, it typically within minutes, these patients have bled out.
Yeah, it's an aorta. It's bigger than your femoral, and that kills you in 5.
So, again, when this ruptures, here's a picture of an aorta, right? It's kind of ballooned out, but it's still intact. So when this ruptures is when we're going to see that AAA. Okay, that tearing sensation in the shoulder blades. Here is another major sign and symptom. Okay, you're going to have what's called pressure paradoxis, which means if you get a blood pressure on this right arm and it's 100/70 during a AAA, you're going to go to the other arm and it's going to be drastically higher or lower. Okay, just based on the circuit of that circulatory system, one side is still used to, okay, I don't have a hole in this side or, this supply chain yet. But the other side is like, oh crap, we got a big, massive open gaping hole in the artery, and you're going to see a fluctuating, a different blood pressure on both arms. The pressure paradoxis. Okay. Typically with a AAA, you will also see a pulsating mass, right? You will see that blood in the abdomen. Thank you. You will see that blood like escaping from the artery, and it's accumulating right there in the abdominal cavity, and you'll just kind of see it like womp, 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 womp. Okay. What else do you think they're gonna have going on locally here? Huh? Maybe some GERD. That's a crap ton of blood to be pumping out directly into that abdominal cavity. So if you like palpate right here, you're going to feel that very obvious, very distinct pulsation. Because guys, if you ever notice, particularly if it's a hot sunny day, you're laying out by the pool, right, and you're laying flat, and you look, you can see your belly kind of pulse a little bit. That's your abdominal aorta, your descending aorta, right? It does that normally, but imagine if we have a big open hole and blood's coming out where it doesn't need to be coming out. That pulsating is going to be a lot more obvious. Okay, so next time you're laying like really, really still, you're laying flat, just like look down, you're like, okay, that's my descending aorta.
Instructor A.
Yes.
So an aneurysm in and of itself isn't necessarily a problem.
It can be fine, but it will eventually lead to a problem.
Okay, gotcha.
Because guys, most of the time you hear about these people going in for like a routine checkup, or maybe they have an injury somewhere else to their body and they go get an MRI and they're like, oh, wait, actually, I noticed that we did the CT of your abdomen, but we also know because you're having, you know, some unrelated issue, and then that's how they usually catch these aneurysms, is just by chance. Now, if you go to the doctor and you're like, I have a headache all the time, or this or that, they can suspect it could be an aneurysm, but typically they find these accidentally because they don't present with any signs or symptoms until they rupture.
Wonderful. That's
Yay!
You might just suddenly drop dead.
So aside from running them to the emergency room, what else?
If you're an AMT or paramedic, fluid resuscitation. But again, guys, recognizing that it's present is vital within your scope. If you're just thinking, oh, they're just bloated because they ate something, their stomach hurts because they ate something wrong, like whatever it is, and you're not recognizing that it could be a AAA and you're not going code 1 back, it's the biggest part of your scope. But yeah, fluid resuscitation. And if it's bad enough, I can try to relay to that paramedic if I'm calling in report and say, hey man, you might want to think about bypassing the ER and we go straight up to the OR. Because what do they need?
Blood.
They need surgery, right? You cannot fix or repair a ruptured aneurysm on an ER table. Like they need an OR table. They need a surgeon. That's the end all be all fix for that aneurysm, that ruptured
It's got to
aneurysm.
become a point of diminishing returns, right? There's the fluid you're going to put in, it's just going to come out where that hole is.
First against time.
Yeah. This is a chart in your book. Just look at it, be familiar with it. It's just kind of maybe how you might confuse signs and symptoms for an MI with a AAA. So just how they distinguish between each other. Okay. Again, guys, this is it's a very sudden onset. Okay. You're gonna have the different blood pressures. You're gonna have that palpable pulsation in the abdomen. Okay. Guys, this is why we check simultaneously radials and carotid. Okay, because if we have a pump problem, right, we need to know right off the bat, is my patient sick or not sick, right? It's gonna be low and go or stay in play, and we can judge that very quickly, usually, by comparing both of those pulses. Everybody good with OPQRST? Kind of jumping in on that bit? Over there? No? This chart's in your book if you have any questions.
I appreciate you walking through that.
Okay, dun, 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 dun. Everybody good? Why we give aspirin? What is it?
It's a coagulant. Sort of. It's a platelet.
Platelet aggregator inhibitor. It makes your platelets slippery. Okay. What's your dose of aspirin?
81.
This is going to be 324, 325, right? We typically give that in what doses.
81 milligrams.
Those
per
baby
dose.
aspirin 81 milligram tablets. So again, guys, that's another question we're going to ask because that's part of our EMD, our emergency medical dispatcher's job. If a patient calls in and says, man, my chest is hurting, I think I'm having a heart attack, or even if they don't even say, I think I'm having a heart attack, that EMD is going to say, okay, do you have any baby aspirin around you? And they will instruct the patient to go ahead and take aspirin if they have it on scene. So that's, again, we can't go over that 324, 325 max dose. So we need to ask them, hey, did you take any before I got here? Yeah, I only had 2 baby aspirin. That's all I took. How many are we going to give them? 2 more. Reach that max dose. What are some contraindications for aspirin? Okay, so any active or recent bleeding, internal bleeding, right? Particularly, you're going to see this if they have any like bleeding stomach ulcers. Okay, because yes, if they're having a heart attack, I want to make those platelets not sticky, but in the same sense, I don't want to make somebody bleed out faster if they're already bleeding and I mess with their platelet composition. Okay, how do we instruct your patient to take it? Hey, here's 4 tablets, chew them up and swallow like normal. How do we instruct your patient to take nitro? Touch the roof of your mouth with your tongue, either spray once or put 1 tablet, let it dissolve, and then swallow normally. Don't chew it up. Okay. Everybody go with nitro? Whenever nitro? Okay. Let's take a 7-minute break and then come back and then we'll start going over EKG at your level, not like the in-depth stuff. All right, so I'm gonna pause really quickly and we will be back. Okay. You can obtain a 12 lead within your scope, but you cannot interpret it. Okay, so we're gonna go over how to obtain one. And then, guys, transmitting this 12 lead is going to be dependent on what service you work at, right? With Grady, everything's kind of hooked up to Bluetooth technology. I can obtain a 12 lead on my monitor. And then even if I, as a paramedic, am questioning it, or if I'm like, yo, this dude is having a major heart attack, I'll go ahead and send it over to the hospital so they can have it for reference, right? Because they're going to, guys, if your patient's having a heart attack, you're going to do several 12 leads en route because a lot of times it's really cool. You can see them progressively get worse. Or if you're treating it with nitro and aspirin, sometimes you can see it progressively get better. All right, so if they are confirmed having a STEMI or an MI, we're going to be getting a 12 lead like every 3 minutes, okay, just to see what it's doing. So I can transmit, I can hit a button, I can select for that 12 lead through my monitor to go through Bluetooth and go to Grady. And then I'll call Grady and be like, hey, bring you a STEMI alert. I just sent the 12 lead over. We'll be there in 10, like, and give a full report. Okay. So, guys, EKG or ECG is going to be electrocardiogram. Okay. The EKG is just a lot more common. You'll hear it referred to that a lot more as an ECG, but it's all the same thing. You're putting those stickers on your patient's chest and you're looking at the electrical activity of your patient's heart, okay? Guys, we'll talk about artifacts when we start playing with the monitor because artifact can significantly change what your cardiac monitor tells you. What do you remember about when we talked about the AED, why we stop compressions when it's analyzing? We want to have the pads on the patient before we plug it into the monitor. Why?
Signal noise.
Yeah, the movement, the physical movement of those pads can give it a false reading. Okay, same thing with this. It's not like an AED with the pads, but it's the same concept. We can get that artifact. Again, same concepts. Body hair can cause an issue. Chest hair causes an issue. If it's like a wool sweater, it's not going to stick to the skin. It's not going to give an accurate reading. Talk about that. Okay. So guys, visually, this is going to be, you need to know your landmarks when you place your 12 lead, when you obtain your 12 lead. Okay, it's funny, there's only 10 wires and 10 stickers that you're hooking up to your patient. But it's called a 12 lead. All right. But I'm going to leave this up here while we kind of play with the monitor. But you have got very distinctive landmarks. You've got to place each of these what we call electrodes to make sure you're getting an active or an accurate reflection of what's going on with the patient's heart. Okay. So that being said, I need a male volunteer that does not have an excessive amount of chest hair and does not mind taking your shirt off. I don't care, something. First come, first serve. All right, so y'all probably want to stand up and come to the front. Hold on, don't have to take your clothes off yet.
Said take your shirt off, so whatever.
I'm really excited about this. All right, let's see. Okay, this is a cardiac monitor that we use at Grady. All right, this is the Zoll. Can everybody see you on Zoom? Is that at a good angle?
Yes.
Yes. All right, so this is the cardiac monitor we use at Grady. Guys, depending on what service you get on, there's different makes and models. Okay, so I'm going to show you this one specifically because this is what we use here at Grady. But once you get on with a company, you have to be very familiar of the ins and outs of that particular brand that they use. Okay, so I come on scene, I'm going to have a patient who I'm suspecting could be having a cardiac event. All right, guys, I could also do a 12 lead to rule out cardiac event. What does that mean? What do I do that? Because are there different things other than a heart attack that can cause chest pain?
Yes.
Yeah, like what? Give me some examples. Trauma. Okay, so if you get hit in the chest, yeah, a traumatic injury can cause chest pain. What else? Respiratory distress. Right? If the patient's having a hard time breathing, you can start to have some subsequential chest pain, but it doesn't mean that it's because your heart's malfunctioning. What else? Heartburn. Literally, like indigestion. Okay, that's a tricky one because sometimes you can have a patient having a heart attack that's like, yeah, it just feels like indigestion. We're gonna get 12 lead. Let's make sure it's not a heart attack. Okay, especially if somebody's been sick for a while. Let's say like they've got pneumonia and they've been consistently coughing. If they're coughing a lot, those muscles can get tired out and they can be sore. Okay, so there's different things that can cause chest pain. That doesn't mean it's a heart attack. But if any capacity, your patient says, I'm having chest pain, and you're wondering, oh, well, they didn't just tell me they've had pneumonia for a week. Because I'm probably not going to do a 12 lead on somebody who says, I've had pneumonia for a week, I've been coughing my head off, and my chest hurts when I cough. That's pretty on track for pneumonia, right? But if it's something where, well, it could be that, or it could be cardiac, always do a 12 lead. Guys, QA would rather see you doing 12 leads on people who it ends up being nothing, to be safe than sorry, than saying, oh, you just got heartburn, you just ate, Thai food or whatever. I'm not going to get a 12 lead and you miss a heart attack. Okay. So part of that is what we call that differential diagnosis. As we were talking about earlier, if you don't have concrete evidence that it is absolutely 100% not cardiac in nature, get a 12 lead, send it off, and let somebody above your scope either confirm or deny cardiac involvement. All right, so this particular monitor, I'll turn it on up here. Takes a second to think and wake up. So, all right, this is going to be your home screen. Okay, you'll also notice that it'll print out just a little bit to get its kind of diagnostics ready to go. All right. All right, so I want to put my patient on a 12 lead. There's certain stickers and certain wires that are going to be attached to your monitor. As this
going to the bathroom.
Huh? Okay. So guys, this is part of your equipment you need to check off at the beginning of every single shift, right? You need to make sure your cardiac monitor works, your battery's good to go. You've got all of your cables, you've got the stickers. All of that has to be in place because what if you get on scene, patient's having chest pain, and oh no, I only have 4 out of the 6 wires, right? All right, so These are gonna be connected to the monitor by this big wire here, but these are for what we call lead limbs, okay? So usually on the side pocket, this one in particular in the back, you'll see stickers. These are called electrodes. They might vary for whatever monitor it works with, but these are gonna be how we transmit that wire to pick up the electrical activity to look at what's going on in the patient's heart, okay? So, when am I talking to my patient? How am I explaining or interacting when this is going on?
I'm gonna take a picture of you.
Okay, so because of what you're telling me, I want to make sure your heart is working like it should. I need to put these stickers on your chest to take a picture of your heart, and we'll go from there. Because if I just come up to my patient and be like, hey, dude, take your shirt off. Excuse me, what? Why? Okay. All right, so guys, make sure you're explaining the reasoning why you're doing this. Especially if it's a female patient or a male patient, be like, I'm gonna have to expose your chest just a little bit, just temporarily. Make sure you got them in the back of the truck. Make sure there's somewhere, it's not like in the public eye. If we have the luxury and the time to do that, right? If they're like sitting pouring sweat and I'm like, yeah, you look like crap. We try to want to get this done as soon as possible, but just preserve your patient's modesty as best you can. All right, so I typically will start with the lead limbs because this will give me an initial reading on the monitor. All right, there are 4, sometimes 3, depending on the monitor, wires with different colors, okay? They should have indications, little markers on the top circle parts that have, you see the letters on them? Okay, so this red one is LL. Where do you think that goes? Left leg. Now, we kind of have a different type placement when it comes to this. It's even on that picture up here. You can put it on the lower leg. You can put it right here on the thigh. You can put it all the way down there on the calf. But we typically don't have maybe that easy access to that patient's bare skin when it comes to those regions. So you can place it down here, like in the lower part of the abdomen. So like the left lower quadrant will be sufficient for the left leg. Okay, so sir, we'll lift your shirt up, they'll put some stickers on you. Guys, do your patient a favor. Put the wires, attach them to the electrodes before you put them on their skin, right? Because if I just put this sticker on the skin, it takes a little bit of force to push it up against this little metal clasp to have kind of that click and that attachment. So, all right, I did that. All right, it might not feel great. Okay, so put the wires on the stickers before you place one on your patient. All right, so the next one has LA. What do you think that means? Left arm. All right, so typically, guys, we'll go right up here. Usually on like the patient's shoulder.
What is it that that's doing? Those 4 in those quantities?
So these are actually really important. Hold on, let me get these placed. RL, right leg. So again, right lower quadrant. And then RA, right arm. All right, so guys, these are really important to make sure you have them on the right direction, correct? Your patient's right, your patient's left. Because what these are looking is at the different axes in the heart, the way the electricity goes through them. If you have these reversed on the wrong side, it's going to come and say you have what we call an axis deviation, which is not a very good thing to have, but it could be simply because they're on the wrong side. Okay, so imagine this. I have a stupid, quirky analogy or reference for this. All right, so you notice we have. Yeah, okay. So you notice we have black above red, smoke above fire. Okay. It's not right for something to be on fire, so your smoke and your fire are going to be on the left side of your patient's body. Sorry, my hands are really cold.
It's all right.
Okay, smoke over fire, so arm and leg, it's not right for something to be on fire, so it's going to be on the left side of your patient's body. All right, and then you just got clouds over grass. I don't have a comparison for the right side for the clouds and the grass. You can go there. I'm being recorded, so I'll be careful how I say that. But anyway, clouds over grass, right side, smoke over fire, left side. Okay, because sometimes you might get like an ancient monitor and these things are rubbed off, or they just have colors and they don't have.
Are they always color coded the same way?
Yes. Colors are always going to be the same way, but they might not have the letters on here and you're like, oh crap, I don't know where to put them. Okay, so that's my stupid comparison. So notice, once I place those lead limbs, what pops up? Okay, some squiggly lines, right? Guys, with a 3 lead or a 4 lead, all right, depending on how many stickers come with these limb leads. Sometimes there's 3, sometimes there's 4. You will get some squiggly lines popped up. But with this 3 lead, the only 2 things that you're going to decipher from the 3 lead is going to be rate and regularity. You can tell how fast or how slow it is, and you can look at, you kind of pacing out if it's regular or irregular. Because guys, it's really important to understand when we do this 12 lead, I'm looking at different areas of the heart, the inferior aspect, the posterior, the septal, the anterior part of the heart. Just because you're having a heart attack doesn't mean that the entire heart is affected, right? Remember that slide where it has the anatomy of all the different vessels, all the different coronary arteries that wrap around the heart? Depending on where that thromboembolus lands, if it gets stuck right here, okay, if there's a clot right here, what part of the heart am I taking away blood flow from?
Left ventricle, it looks like.
Mm-hmm. So directly right here, if this part's clogged, what is this part of the heart called? That's the septum. So if this part, if it got clogged right here and it was preventing blood flow through this artery to the septal part, that's a septal heart attack. It's particular areas of the heart, depending on where that clot gets lodged. Now you can have a global heart attack, right? If the, where is it? Typically it's up here with a circumferential branch. If that gets clogged, that is the initial hub for all of the branching coronary arteries. You'll see that effect in all areas of the heart. But just depending on where that clot gets stuck, depends on what part of the heart is going to be ischemic and what part of the heart will start showing those signs and symptoms. It doesn't have to be the entire thing. Does that make sense, everybody? I can pass this around if you want to, but please don't break it. Very old. All right, so in order for me to look at all of the different areas of the heart to see if, you know, some part of the heart is affected, I've got to put the additional wires on, right? So I'm going to get the additional cables, which they come in a separate attachment, okay? For this monitor, they hook up right here to this hub. Just kind of click them in. My monitor is going to yell at me because it's saying, hey, you've plugged in the additional wires, but you're not in the 12 lead mode on the screen just yet. So again, I'm going to be nice to my patient. I'm going to put these on first. All right, so did I really have to expose my patient's chest putting the lead limbs on? No, not really. This is where, especially if it's a female patient, we're going to say, I'm going to have to temporarily expose your chest. Are you okay with, you know, this person being around you? I'm just letting you know what's happening so you don't think I'm like feeling you up type thing, right? We're explaining what's happening. All right, so this V1 and V2, okay, this is going to go to the 5th intercostal space bilaterally across from the sternum, okay? So now you need to kind of count down the intercostal spaces, but you'll get more used to where that placement should be on patients. So again, sir, I'm going to lift your shirt up. I'm going to put a couple of stickers on your chest. All right. So 4th intercostal space on the right side of the sternum, and then mirror it on the left side. Okay. All right, so we've got V1 and V2 placed. Okay, we're gonna place V4 next. Don't worry about V3 yet, okay? So V4 is gonna be the 5th intercostal space, mid-clavicular. So we're gonna go down 1 kind of space right here. Sorry for the nipple here. All right. And that midclavicular line, we're going to place V4. Could be over just a little bit. All right, V5 and V6 are just going to kind of wrap around that fifth intercostal space off to the side. And the technical placement for V3, you're going to put it in between V2 and V4 to make a diagonal line. Okay, so just place that right about there. All right. Now this is where it comes, especially with females, if they bless up top. All right. Remember, you might have to displace breast tissue to get this V4, V5, V6 on their chest. Remember, assess, assault. Okay, so literally you might have to go up underneath any type of bra, but if you're having to move the boob out of the way, just do it with the back of your hand, place the stickers, and then let it fall back down. Huh? Don't cup it. Okay, and just let them know what you're doing. So, ma'am, I'm just having to, kind of move your breast so I can place these stickers where they need to go. It's a little easier for like females to do it. Females be like, all right, honey, move the girls out of the way. Gotta put these on real quick. Okay, so, but just have that professional. So if they've never gotten a 12 lead before and they're like, hello, what you doing down there? Just explain to them what you're doing. Okay. So now that all of these are attached, I'm going to go to this number, this button right here that says 12, right? This is going to take it to the 12 lead version. So when I push this button, a lot more squiggly lines pop up, right? So you'll notice there's like 2, 3, AVF, V1, V2, V3, V4, V5, V6. Okay, all of that stuff, that ABR, all of those stuff, those are telling me those are different areas of the heart, right? So V1 and V2 is telling me what's happening on the septal aspect of my heart. 2, 3, and AVF is telling me the inferior part of my heart, okay, and so on and so forth. This is paramedic stuff, guys. I don't expect you to understand it, but freaking cool, right? Pretty cool. So all of these squiggly lines are telling me what's going on, and the different leads are telling me what different areas of the heart I'm looking at, okay? So with this, right, so sir, I need you to be nice and still for me, because notice what happens if he's moving around or if we're hitting potholes driving down the road. All right, you guys see that? That's what we call artifacts. Okay, we can avoid this if we do a 12 lead in a stationary, like on scene. If your patient's having like chest pain or something like that, get a 12 lead on scene before you get them in the back of the truck, because you're moving around. It can change the way things look. Okay, sometimes we can't control it very well. Like if a patient's having like significant respiratory distress, start to hyperventilate for a second. I don't have to work. Like act like you're. Okay, you still got it. But anyway, that significant movement of their chest wall, or if they're moving because they're in pain, can cause that artifact. All right. So we tell them, if it's possible, if we can control it, sir, I need you to be nice and still. Don't move, don't talk for 30 seconds. I have to take a picture of your heart, and if you're moving and talking, it's not going to work. Okay. So you would hit, there's a button right here. It's got a camera. That's just going to say, I want to capture the image of this 12 lead. Okay. You need to put in the patient's age. Okay. So how old are you, sir?
27.
Patient sex, and then the patient ID number, that's at the very bottom. So if you transmit it to like Grady, like, hey, patient, the ID number is blah, blah, blah. Or you can actually put in like a first initial, last initial type thing, so they can say, because they get 12 leads all day long. All right, so they can say, this is the one I want you to look at. All right, so you'll go down and you'll say, okay, sir, nice and still, don't talk, don't breathe. It's acquiring the 12 lead. It's processing the image. Once it gets done acquiring, it's going to say that it's analyzing. Okay, so once that first green bar fills up, you can tell them, okay, you can move around a little bit, or you can breathe like normal. Okay, but then it's going to take a second, and that computer brain in the monitor is going to process the different spikes and the different curves and the different distances between all of these different squiggly lines, and it's going to give me an interpretation. Yeah, some interesting T waves. Okay, now when you go to that 12 lead, there was also, before I exited out, there was a button that had an envelope on it. That's what we pushed to send it out to Grady, to, you know, another unit, something like that. So if you're going to transmit it. So it'll print out, and I'll tear it off. There is, it will tell you right here, all of these numbers mean different things. Okay, but it will give you an interpretation. So are you okay with me sharing findings with your classmate?
Sure.
You're dying. I'm just kidding. So
If I was dying, I'd
sinus,
hope you'd be calling 911, not just casually reading them off.
sinus rhythm with a short PR interval, early repolarization. So the ST elevation with normally inflicted T wave. That's what I kind of saw first off. So borderline findings for his age group. Okay. If there were any major indications that there was a major cardiac event, any type of dysrhythmia, it would definitely tell you right here, and your monitor would start yelling at you. Okay, like beep, 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 we're having a cardiac event. Guys, if you get a reading like that, what do you need to do? Really quickly, okay, so yes, stay calm. Okay. Yet? Because what did we just talk about with this? What happened with this? If you get a reading that says you're having an MI or you're having something catastrophic happen, say, okay, keep calm, go back, make sure all of your stickers are on the right spots. The best that you can, make sure your patient is very, very still, and get another one. Because sometimes if they're moving, or if you've got these lead limbs, you know, on the wrong side, it can tell you a big problem's happening when in reality it was operator error. Okay, so just get a secondary 12 lead. If they're nice and still, you know for sure your stickers are where they need to be. Okay, not time to panic, but all right, this is legit. Okay, so that'll print out. Again, you'll transmit these. Guys, if your patient is having a cardiac event, again, once you get them loaded up and you're in transport, every 3 to 5 minutes, you're getting another 12 lead. Keep the paper strips, all right, because they're also going to be timed, right? This is going to say the exact time that this was captured. So if you walk through the door and you hand the doc 5 12 lead strips, first of all, he's going to be like, thank you. This is amazing. I love having that much information. But he's going to kind of space them out chronologically. Did it get better? Did it get worse? Where do we stand? You know, type thing. Okay. So that is going to be getting a 12 lead. All right. You cannot interpret it. You can obtain it. You can send it off to be analyzed. All right.
Why do they still have paper?
It's just for a printout because all of these itty bitty red boxes right here are increments in measurement. So that's part of the analysis. Like if, you know, we have like a first or second or third degree block, then we can count it out using those measurements. It's just a good reference to have. Okay. So here's your free 12 lead for the day. There you go. Cool. All right, so I'm gonna have you stay hooked up to the monitor though. All right, so exit 12 lead, I'm gonna go back to my home screen. I sent this off to the doctor. He said nothing's going on. Sweet. Okay, this is gonna take me back to my 3 lead. Look. And then also down here, you notice it's counting my heart rate and somewhat of a respiratory rate by the movement of the wires, right? There is another device that, unless an advanced airway is placed in your patient, you won't really use this. Does anybody know what this is? Huh? It's not SpO2. This is your SpO2. Okay, so here's your SpO2. It's the same as the other piece of equipment. It's just connected to the monitor. So sir, I'm gonna have you place that on your finger. Rest your hand nice and gently on your leg. And it should pop up if it's reading. See, it says it's searching right here. And you're actually gonna get a waveform for that SpO2, and it'll tell you what it is, okay? This is called my end-tidal CO2. So if I have that advanced airway placed, I can hook this up to the hub of the airway in my BVM, right, in between the two, and it's going to measure how much CO2, the measurement of CO2 that's coming out of my patient's airway every time they exhale.
Cool.
Okay, super cool. Let's see, it's on this side, yeah. So what happens here is you kind of plug this in on the side. It's not picking up. Okay, so does anybody know, did I tell you guys what the normal range of CO2 is? 35 to 45. If I see anywhere in between those numbers, I know everything is okay. If I see lower numbers or higher numbers, I can infer that my patient's either alkalotic or acidic, right? Just too much pH, too much CO2 is being trapped or retained. I believe it's millimeters of mercury. Don't quote me. Yes, 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 yes. Okay. So with this, I'm going to try my best not to pass out and try to get this working for you guys. Check my going on. Might go flying. All right. So all right, it's not gonna work. I don't want to pass out. But typically, this would be connected to the advanced airway as we're breathing for the patient. Okay, so it's giving you, it's giving you a number. That 32 is measuring the CO2. It's giving you a respiratory rate, and those little like hill looking, kind of the plateau, that's telling you how I'm trying to breathe. There's different things, like if we see what's called a shark fin, where you see those are nice kind of even plateaus. See how those are nice and like even blocks? If we get kind of like a spike at the end, that's telling me that that's a different type of respiratory effort or something else that's going on in the alveoli. Okay, so as an AEMT, it's part of your scope to attach this and interpret this. Okay, but this is something that you might see on the monitor. This is something that we can keep track of if an advanced airway is placed. Okay, so we're gonna get out of that, but you see the difference between a 3-lead and a 12-lead. There's not a lot that 3-lead can tell me besides how fast or how slow, and if I see a regular rhythm. You've got to get that 12-lead to interpret if there's any type of heart attack or bundle branch blocks or first, second, third degree heart blocks, all that stuff. Okay? Questions, comments, concerns?
Looks like the average time that this usually takes, like on scene.
2 minutes. Yeah. Guys, again, it's just going to be that repetition. You're going to know exactly where to place them. Hey, really quick, let's expose. I mean, it takes no time at all once you've done it 1,000 times.
So why is it called a 12-lead if there's only 10 wires?
No, that's a paramedic. We can get to that question. All right, so I'm going to remove this from my patient now. Be nice to your patient. Again, guys, if they've got like a wool sweater with excessive chest hair, you might need to like kind of push it down. You can try to give them a free wax job, but the stickiness on these electrodes are not near as adhesive as the AED pads. Be careful though if you're trying to push it down, because what can the monitor pick up on? Your movement, right? So what I normally do, if they do have chest hair, because I got some nipple hair up there, right? I just say, I'm going to give you something to remember me by. I'm going to leave the stickers on. They can take them off themselves. But I get all of my wires all together. And I get them nice, get all the slack out. And I say, you're going to feel a little tug on 3. Okay? 1, 2, 3. All right. I'm going to let them inflict pain upon themselves, pulling hair out, whatever. All right. But that's just always how I get all the cables off. It's just
Yoink.
Okay.
They don't have to replace them too, right? They can just plug theirs up. Right?
Typically, there are some of the machines in the hospital have different attachments and they have to replace. But if not, they can just, hook their own wires up.
Cool.
And sometimes you'll have a patient that has electrodes on from like 2 weeks ago and they just never took them off. Or like, especially the females, like one gets up underneath the boob and they're like, oh, forgot that one was there. So.
Is that a thing that actually happens on a quasi-regular basis, or is that just a once in a blue moon kind of
Very
thing?
regular basis with great. Our frequent flyers, especially if they don't have means, like if they're homeless and they can't take regular showers, they'll be on there for a very long time and be all gurgling.
Can you reuse them?
No. No, you get a fresh set. All right, so everybody okay-ish with the monitor? Okay-ish? Ish. Okay.
Yes, ma'am.
All right. Well, thank you for being very eager to take your shirt off in front of me.
Let me be big for the medical instruments.
All right. Hop back, and we will get back at lecture. Okay. All right, so guys, as much as I'm going to tell you and let you know more knowledge than what is at your scope, each part of this wave, this normal, what we call normal sinus wave, means something, okay? So that first little hump is going to, for the most part, that P wave is going to tell you about the performance of the atria. Okay, the atria. It's going to tell you about the performance of the atria. This QRS complex, this spike that you see in the middle, who do you think that's going to tell you the performance of? Ventricles. Okay, and that second spike, that second bump, that T wave, is going to tell you that everything's going back to normal. This is our repolarization state to get ready to be in line for another normal contraction. There's a whole bunch of stuff that goes into play that makes sure that all of this is happening in the same fashion every time. Okay, but just for now, before you get into paramedic school, P wave is your atria, QRS complex, that whole thing right there is your ventricles, and this is everybody getting reset back on the same page. Is that okay? It's not jumping too deep. Okay. You want to watch the stupid video? Okay. So now you kind of know what is associated with the different kind of spikes in the strip. This is just, I just think it's funny. These little doctors dance to represent. So when you see them moving anything with their upper extremities, what do you think they're indicating is firing? The atria, the upper chambers, and anything like with their legs is the ventricles. Okay. It's stupid and silly, but now that you understand it, you can appreciate it.
Contact-free rentals help protect the communities we're a part of. So if you need
This is paramedic level. You're on that. That's not a real rhythm. Okay, so there's something cute and stupid. Yeah, that Wolf Parkinson White, you notice that throughout the ventricles, he was kind of like doing the loop around. There's a roadblock in the electrical, the conduction pathway, so it's having to like do a detour and go around different things to get through, to contract. Okay, are we okay-ish? It's a lot, I know, sorry. Okay. So again, guys, you can have significant heart surgeries, you can have bypass surgeries, you can have what we call stents placed in your heart, particularly where the vessels are, the vasculature, to keep those arteries nice and open, to make sure that they don't clog up again in the future, so we don't have future heart attacks. What about those? If your patient has a significant scar, like this big in the middle of their chest, that means they're a cardiac patient. Okay, whether recent or an older scar, they have significant cardiac history. We need to talk to them about that. All right. All right, pacemakers. All right, so you guys saw in that little video when it said pacemakers, it had a wire connected. He was trying to like, you know, pump by itself or contract by itself, but when it paused, the pacemaker said, hey, all right, you need to contract. Something is wrong with the patient's who if they need an external pacemaker.
SA node.
The SA node, right? The SA node is not picking up on every single beat. It's not giving that message for every single beat. They might be skipping beats or they might be skipping several beats. Okay, so this implanted device, which is that, guys, it's pretty small, okay? You can see it on the right upper area or you can see it on the left upper. It just depends on the cardiac surgeon's preference, okay? But what's happening here is this piece of equipment, these wires are going straight to that right atrium where that SA node is. And it hooks right up to that SA node and it gives that stimulus if the SA node doesn't do it on its own. So if the SA node fails to fire, the pacemaker will be like, nope, okay, you should be having a beat, right? They can set these pacemakers to beat at exactly 70 beats per minute if the SA node doesn't fire.
Is there a reason why it would be like set lower than that?
Like where? How?
I mean, like for the beats per minute. Because my
Possibly.
is like 60.
Is he a smaller guy? It just depends. There's a rhyme and a reason for everything. He might be on other medications that if his heart rate gets too high, it might mess with his blood pressure or something like that. So maybe, possibly. Usually average is like 70 beats per minute. Okay, so that's what it's going to look like. That's what it does. Guys, we've already talked about this for the AED pad placement. Remember, we don't want to place an AED pad where? Directly on top of the pacemaker. If we fry or short circuit that pacemaker and we get a pulse back, we're not going to keep the pulse for long because they're dependent upon this piece of equipment to have a regular, consistent heart rate. Okay, everybody with that?
Is there always going to be a bump?
Usually, yeah. I mean, this is a lot smaller than they used to be. They used to be like yay big. So they're getting smaller and smaller, but you're still going to typically see some type of raised material.
And when you say typically, that means there are some you can't see?
I mean, probably. I don't know every single make and model of pacemakers out there, but I don't think they've gotten to the point yet where they're undetectable.
Assuming they were low profile enough that you couldn't just see them at a glance, what would give away that there is one there?
And I wonder if they ever get the technology to make them that small, if they will make them that small, because if their patient's unconscious and unresponsive and I don't see something obvious, how am I supposed to know it's there?
Yeah, maybe they'll
Or just tattoo with the outline. Okay.
All right. Yeah, guys, this is a great piece of equipment, but it's equipment. It can fail, right? If we have a patient who has a pacemaker and it's not working, it's failing to fire, they're going to go into that state of bradycardia or that irregular heart rhythm. That perfusion is going to drop. They can have syncopal episodes. They can be dizzy, altered mental status, all that stuff. It's really cool with these things. If you put somebody on the monitor and they have a pacemaker and it's working effectively, so here's that, you will see it's called a pacer spike. So if you put them on the cardiac monitor, you will literally see like a vertical line right there, right before the P wave, because that's the firing for the atria, the SA node in the atria to start its cascade, if you will. All right, you might also see patients with a implanted machine, very similar to that, and it could be a defibrillator. Okay, so instead of dealing with the atria and that SA node, the patient has some sort of condition where they consistently go into that V-tach rhythm, right? Because this implanted defibrillator is what compared to what you guys have already learned and used?
Smaller one that's autonomous.
It's an internal AED, right? So it's planted. It has sensors in the heart that if it picks up on that V-tach or any ventricular dysrhythmia, it sends an internal shock to put it back in that normal sinus rhythm. You can have a patient who has a dual pacemaker and defibrillator. Yeah, they all jacked up, right? So if we see that there, we can ask them, hey, is this a pacemaker? Hey, is this a defibrillator, or is this both? Sometimes they know, sometimes they don't. But we can infer that they have significant cardiac history if they have an implanted device, right?
If they have an implanted defibrillator, is it safe to use an AED on them?
Just put it around the defibrillator.
Sure.
Okay. Guys, this internal defibrillator, if it goes off, it won't shock you. If you're touching the patient and that internal defibrillator goes off, you're not going to get any electrical current from that internal. Okay. You might see an ancient dinosaur piece of equipment called a life vest or an external defibrillator that these patients will wear. Typically, guys, really the only time you'll see these is if the patient is not healthy enough to undergo the surgery to implant the defibrillator, but they walk around with like this little gun holster looking thing, and it's pretty much got an AED hooked up to him at all times. If you're touching a patient when this goes off, you will get shocked. These things are very annoying. They send out a very loud beep when it's about to send a shock. So if you're just like hanging out with somebody that has this and you're like, touch them in any capacity and you hear that alarm, be like, oops, sorry, bro. Like, step away and clear the patient, okay? You will get shots if you're touching the patient if they have the external defibrillator vest.
How much warning is that? Like,
It's usually about 10 seconds. But if you do it 10 Mississippi, you should have enough room to clear. Okay, an LVAD. What does it stand for? Left ventricular assisted device. Guys, these are freaky. They're very rare. I've had one call with an LVAD patient. What is happening with this LVAD machine?
It's pumping the left ventricle.
Okay, so your left ventricle is tapped out. It's not working. It's not doing its job. This piece of equipment directly bypasses the job of your left ventricle and does all the pumping for the heart, like for it. So you will not have a palpable pulse
because it's just a continuous flow
on a patient who has an LVAD. They are zombie patients because it is just a continuous flow. There's not a pulsating movement of that blood from the contraction of the left ventricle. It's just a constant kind of whir. All right, so you'll go over these patients, you'll be like, okay, radial, don't have a radial. carotid, I don't feel carotid, but you're talking to me, like what's going on? If you are very, very still and very, very quiet, you can feel a very subtle kind of like vibration when you're palpating these pulse points.
Can you hear anything?
If you put your stethoscope up to it, you can hear just like a.
Can you take their blood pressure?
So they're going to, but they're moving towards recommending that we don't take a blood pressure because it can affect the machine. It's just as long as they're showing good signs of perfusion, then that's good enough. Okay.
So is that actually external to the body?
So you will see a little, it's almost like how a feeding tube would look. It's just like a little connecting side on right here. They'll probably have a scar here, but they wear like a little fanny pack that keeps like the extra batteries and like the monitoring system for it. No, this is internal. Yeah.
Are they typically like waiting for a heart transplant?
Yeah, guys, this is very last resort. If you have an LVAD place, you are waiting for a heart transplant. And guys, this is not done lightly. These patients go through months of education and training about these LVAD devices before they're placed. They don't just be like, oh, hey, your insurance covers it. Here, yeah, here's an LVAD. You get an LVAD. You get an LVAD. This is a very, they take this very seriously. So your patient, if they're conscious, is pretty much going to run the call. That's what my lady did. Because it was something like her monitor kept going off or her battery kept going off. And I walked in and she goes, honey, we're going to be going to St. Joe's today. And I'm like, oh, all right. She gave me a little card. She goes, that's my surgeon. You need to call him and talk to him. And then after that, you need to call. And like, she knew exactly what to do. And I'm like, thank God, because
I can
that was the
imagine
first time I come in contact.
That loses power, you're going to literally die very quickly.
Okay, and AHA has just made the change. Used to, we would not do compressions on a patient in cardiac arrest that had an LVAD. Why?
You can't compress that.
Well, think about the motion though. We can compress that left ventricle for it, right? But
the actual device, that would be like.
Yeah, what are you gonna do if you're doing that motion with something? Rip it out, right? But now AHA is like, well, better than nothing. I guess is there.
You can't make them
They
more
have
dead
science
by-
behind it, but they've changed that. You now
can't make them
do.
more dead by doing it wrong.
You now do compressions. You can't do compressions on an LVAD patient. Used to, we cannot. What if it's broken? It's equipment. It fails.
Plug it in the wall.
No, that's not how it works. All right, so super, super cool, guys. Again, if they live with somebody, their family members, their significant others, go through this training, this education as well. So they should hopefully be able to provide information for you. Because it's very rare that you come in contact with these.
Sometimes finding a car is a necessity. If that time is now, Car Crew's contactless service.
The heart has 4 muscular pumping chambers: the right atrium, the left atrium, the right ventricle, and the left ventricle. The left ventricle pumps blood out through a large artery called the aorta to supply the body with the oxygen and nutrients it needs. In left-sided heart failure, the left ventricle is not able to pump enough blood to the body. The 2 types of left-handed heart failure are diastolic, where the left ventricle can't relax enough to fill with blood, and more commonly, systolic, where the left ventricle can't contract strongly enough to push blood to the body. In severe or end-stage heart failure, the heart is getting weaker and doesn't respond to medication. For left-sided end-stage systolic heart failure, a doctor may recommend an implantable left ventricular assist device, or LVAD, to help the heart pump enough blood to the body. An LVAD is a small mechanical pump implanted inside the chest or abdomen that takes over the job of the weak left ventricle. Blood flows from the left ventricle through an inflow tube to the pump. The pump pushes the blood through an outflow tube into the aorta. From here, the blood travels normally from the aorta to the rest of the body. A cable, called a drive line, connects the LVAD pump inside the chest to a control unit located on the outside of the body. The control unit is a small computer that controls the functions of the pump and alerts the patient if there are any problems. The pump and control unit receive power through a cord connected to a battery pack. Finally, the control unit and battery pack are held in a lightweight patient pack. An LVAD may be a temporary treatment until a heart transplant can be performed. Or if the patient isn't able to have a heart transplant, an LVAD may be used for destination therapy, which is long-term treatment.
Dieting is 80%.
Okay, so a little
freaky.
better imaging. Yeah, it's great. All right. Cardiac arrest. Guys, we've already talked about this. Everybody go with 80. We've already done all this. We've already talked about all this. All right. Last one to wrap it up, because, okay, I guess it didn't come back to congestive heart failure, but I don't know why, because it's pretty important. Guys, that congestive heart failure, so it kind of touched on it in the LVAD video, right? Particularly, we can have left-sided or right-sided heart failure. If you have either left-sided or right-sided, you're going to be categorized as having congestive heart failure. Okay, the most common that we are going to see is left-sided heart failure. That's directly involving the performance of who?
Ventricle.
That left ventricle. We will usually see this left-sided heart failure in patients who have chronic, uncontrolled high blood pressure. Because think about it, guys. If you have got either that athero, which is typically the cause, or that arteriosclerosis, that left ventricle is having to pump and perform harder and harder and harder day in and day out to overcome that SVR, that systemic vascular resistance, right? Okay. After a certain time frame, it's going to say, what?
I'm done.
Dude, I'm tapping out. I can't do this anymore. You're not changing your lifestyle. You're not taking your meds. You're not taking care of yourself. I can't perform like I need to anymore. So you'll start to see it will kind of become, there's something that we can notice in this QRS complex, that if it's like way high, all right, that's what we call left ventricular hypertrophy. So if we see that big spike, that's telling me that that left ventricle is having to do this. If we see that, that's probably going to lead to left-sided heart failure if they don't take care of it. Okay. So that left side, that left ventricle actually becomes like kind of almost swollen because those muscles get bigger and bigger because it is a muscle, right? The more you work out your muscles, the bigger they get. And it doesn't have that fine kind of motor skill to really contract anymore. And it also just doesn't have the energy or the effort to do it anymore. So that left ventricle is not working. It's not pumping blood that one-way direction to the rest of the body. What do you think the most common signs and symptoms for a left-sided heart failure patient? Go back to that blood flow. We've got to know normal before we know abnormal, okay? If that left ventricle is not pumping like it needs to be, all of that blood that's not being pumped out is going to start creating and building. It's going to start building in that left ventricle and creating pressure. And is eventually going to start pushing up against those one-way valves, right? It's going to force those one-way valves open, and where that blood, that fluid is going to start backtracking.
Into the lungs.
Where does the blood supply that goes to the left ventricle come from? The lungs. All right, so pulmonary edema, that fluid in the lungs, particularly that blood that's not getting pushed out by that left ventricle, it builds and builds and builds, and all that back pressure says, screw you one-way valves. I'm going to open you up. I'm going to come back through that right atrium or that left atrium, and I'm going to find myself back into the lungs. Okay, it goes back to where it came from, where it comes from, when we have that left ventricle not pumping like it should. Fluid in the lung, good or bad?
Not good.
Bad. All right, so particularly guys, if your patient is coughing up what? Anybody know? Pink, frothy sputum. Okay, it literally looks like if you go get like a strawberry daiquiri and all of like the foamy stuff on top that's not quite like the ice in the drink, but it's just like the bubbles, that pink bubbles, that's what it looks like. Pink frothy sputum is a very, I'm gonna say 110% indicator that we have fluid in the lungs, that blood in the lungs, and we're coughing, that their lungs are gonna be full if they're coughing up that pink frothy sputum. That's a bad day. What intervention that's in your scope of national level will be great for this patient?
CPAP.
CPAP, right? If they're conscious, if they're not actively vomiting, we can get that positive pressure and displace all of that fluid, get it out of the alveoli temporarily so we can have gas exchange. So they don't effectively drown in their own blood.
Too bad we're in Georgia.
It's coming up in the next few years. Not in Georgia, so the national scope is within your level. Okay? Because that's a patient, if they've got that pink frothy sputum, it just makes you want to take a nice big deep breath. Because it's very uncomfortable to watch them go through that knowing that they're effectively drowning. So the only thing that if you guys don't have an A or a paramedic en route or on scene, the only thing you guys can do is bag that patient. Okay. Pink frothy sputum, left-sided heart failure, pulmonary edema, not good. Okay. Guys, if you forget left-sided heart failure backs up in the lungs. Left lungs, LL. Okay. Right-sided heart failure is going to be more so the performance of the right side, obviously. It's not forcefully pushing the blood through the rest of the track of the heart to eventually get out to the body. So where do you think that blood, where does the blood that dumps out into your right atrium or the right side of the heart come from? The rest of your body. Inferior and superior vena cava. Right? So typically because of gravity, we will see all of that blood and that fluid accumulate in your patient's feet. We call that pedal edema. The little piggies and the little feet will just be like blown up like a balloon. Their ankles can get very swollen. And if it gets really, really bad, there's something that a test that we do, it's called, we take 2 fingers and we push in to the skin. And when we remove our fingers, we can see like the indentations of your fingers in the patient's skin still. That's bad. That's called pitting edema. If that is present, we've got some significant backup secondary to right-sided heart failure. What do you mean? Pedal edema is where you'll see the feet are swollen, because typically, guys, you might see these patients be a little lethargic. They might just feel tired because they don't have that appropriate cardiac output. If you're tired, what do? You sit down, you lay down, all right? And then just gravity is going to pull usually to their feet and their ankles. And then if you can see the indentation of your fingers, it's called pitting, P-I-T-T-I-N-G, edema.
So are they more susceptible to clotting then? Because you have like all that.
What about CHF? Everybody good? Left-sided heart failure with CHF, backs up to the lungs, pulmonary edema, pink frothy sputum, bad day, CPAP at the national registry level. Bag of bitch, state level.
For right-sided failure, what do you do, since you can't obviously fix that with CPAP? Just
Right-sided, you're going to see this systemic, what we call systemic edema. Typically presents itself in the lower extremities just because of gravity. Yeah, there's nothing that you can do or I can do really for right-sided heart failure.
get into the hospital as fast as you can.
I mean, if they're stable, if their blood pressure stable, that's not a code 1 ride back. But yeah, if we've got pulmonary edema, that's a code ride back for sure. Okay. Usually these right-sided heart failure patients are on medication called like water pills or like a diuretic. it stimulates the kidneys to pee a lot more to get rid of the excess fluid that's accumulating, and it usually keeps the fluid in check. But if they're having a bad diet, like salty foods, or maybe they need to up their medication or they didn't take their medication, then we can see that fluid start to really kind of accumulate. Okay. All right. Questions, comments, concerns on anything that we've covered so far? So guys, we're gonna watch this video, then we're gonna be done with cardiovascular. We're not gonna be done before lunch, sorry. I forgot in a normal semester, this is all we lecture on in one day. So we'll start respiratory, we'll finish up respiratory after lunch, then have playtime, okay? This is a really, really cool video. Some of you guys might have already seen this. This was, I think, maybe early 2000s. It was a reality show that the BBC was filming for like flight medics. It was just, you know, kind of like the live PD, but it was following the flight crews with the helicopters in and out. I don't know if this has ever been captured on video aside from here. One of the dispatchers that was working that day started feeling really not good. You'll see that pale, cool, clammy presentation. He actually looks like gray in color. He looks like shit, right? He's sweating profusely. He's got that gray color. He just has got that, I don't know, I just don't feel good, kind of that air hunger, like can't catch your breath. The paramedics that were on, you know, shift that day put him up to a 12 lead. He's had a massive heart attack. All right. So they're very British. So sometimes you can't really understand what they're saying. So I'll pause and break it down for you. But because this dude was having such a massive heart attack, he actually goes into cardiac arrest on camera. So he codes while they're filming this. So yeah, we're gonna get to watch that. It's really cool, as morbid as that sounds. Okay. We're not gonna watch the whole thing, don't freak out, it's like 15 minutes long. Okay, so the first part is just an introductory, like how the days go in, all this stuff, kind of what their job is.
Is there such thing as a not massive heart attack?
Yeah, it can be isolated to just like one area of the heart. But this was just like in all areas of his heart. Okay, so not really feeling well. All right, his color right here, no bueno, right? Compared to that nice pink appearance, he almost has what we call like the ashen, that gray color. If your patient ever has that color, something's wrong. All right, that is a very strong indication of poor perfusion. Typically, that's going to be usually from a pump problem. So you heard him, they were taking his pressure, they were asking, do you have diabetes, asking medical history, all that stuff. See how he just can't get comfortable? He's just kind of like moving around.
ECG looks a little bit dodgy at the moment. I'm not 100% sure what it is. Okay, the blood cell on the side of coaches. I'm just going to make sure that's out, yeah. Okay. Just pop that up there for us.
Okay, so did you hear? ECG looks a little dodgy.
That's a nice euphemism.
He's, well, and that's, I'm not going to straight up say, dude, you're having a massive heart attack to my patient, right? But he's saying, hey, it's not looking 100% like it should be. We're going to take you down to whatever hospital to run some more tests. He just gave him aspirin. They're starting that chest pain protocol, right? So that's another thing, guys. If you can recognize, if you talk to that doc after you transmit that 12 lead, you'll be like, yep, this is a heart attack. You need to be careful how you deliver that to your patient, right? Because if you straight up say, yeah, dude, you're having a heart attack, what's going to happen with the patient? They're going to freak the F out, right? What's going to start coursing through their bloodstream? Adrenaline. It's going to make that heart that's already dying beat faster and require more oxygen and make the problem worse, right? But do we have to go code 1 with these patients back to hospital? Yeah. Does that mean lights and sirens? Yeah. So every single time, every STEMI I've ever ran, I'm just gonna be like, this is almost the exact same approach. This is not looking 100% right. We're not exactly sure what's going on. Because guys, the only 1000% way that you can confirm a heart attack is happening is getting that blood drawn and looking at those levels. Technically, you're not lying. Not 100% what's going on. We need to get you to the hospital so they can run more tests and give you some more treatment down there. And I just tell them, dude, I hate traffic. I don't want to sit in traffic, so we're just going to turn the lights and sirens on so we don't have to sit through this traffic. Is that okay with you? We'll just get there faster. You got to kind of downplay it. Because if you look at your patient and be like, dude, you're having a massive heart attack right now, we have to get to the hospital as fast as we can so you don't die. Great way to say that, right?
What if they don't want to go?
Then you call medical direction like I did with my one patient. And then you say, bro, you're having a heart attack. Like, use fear factors for that if they're trying to refuse. All right? So again, he just looks left.
To the secondary site, or the rest of the crew, our crew, yeah.
So again, he's sweaty. Doesn't feel good. He goes unresponsive. He's going out. His heart rate's 180 right now.
That's high.
Yeah. Now watch what he starts doing. Watch his arms. What is he doing?
That's
Terrible compression.
That decorticate posturing and that decerebrate posturing. All right, so we usually see that posturing if we have immense pressure in the brain or if we have like profound hypoxia. Okay, he just went to cardiac arrest. He has no oxygen flowing, so he's actually, you're seeing him posture because of that just global lack of oxygen in his body. That's what it looks like, just kind of that, just like uncontrolled, like spastic motion. Watch him get shocked. You'll see his body kind of tense up.
Go on, Grace.
You see him starting to breathe on his own. Commercial. See now he's starting to breathe on his own.
Grace, it's James, you're at work. It's just oxygen, it's just James, you're at work. Just relax. Okay, Grace?
pushing the 7. Outside of 35, it was me, it was looking at the cut out was on the way, we sat there, it was really Chris. Says he's back with us now, so.
Yeah, they gave him a free wax job right there.
Okay, so we just realise that. Okay, you're on the sinus rhythm, okay? He's got a lining, he's had no adrenaline, he's had aspirin, he has a buckle, CPR instructions.
So what did they just do?
They went through what they did.
Yeah, they recapped, right.
On the same page.
He's back in normal sinus rhythm. We've got a line in, which means they've got an IV, he's getting fluids, he's had no adrenaline, they didn't have to give him any epi. All right, we've shocked him twice, they're going through the steps. Have we missed anything, right? You're gonna need to bounce all the stuff off your partner to be like, hey, should we do anything else? Did we do everything right? Like they're doing a recap to make sure that they didn't miss anything.
That's shocking, twice trying to get the heart back into a normal rhythm. And we've worked on him with some CPR. We managed to get him, get some output. And we're just trying to stabilise him now to get him down to the LGR so that we can get some of the cardiacs into capture him from there. All right, Chris. All right, mate. You're okay. You're work. What's the right? Okay.
I never got the ambulance so fast.
Yeah.
Hopefully we can do
He did CPR on the steps. All right, so they get him transported,
Absolutely.
get him packaged up.
And they'll be taken where they go from there.
We're scared.
And that's him, like 2 days later.
Because the one stage now is just, it was just like that. I'm just going to open or move. The pins and needles was horrendous. I then realised that there was something going on. I knew this wasn't any type of indication. It was going down my legs as well, pins and needles down my legs. And it's not a thing I would like to experience again.
Okay. So he said he felt that pins and needles in his arms and his legs. But yeah, that's pretty cool. Again, guys, that was a witness cardiac arrest. They had medical equipment literally right there. They could shock him back, but again, don't always expect that outcome, them sitting upright, talking to you totally normal 2 days later. But that was optimal conditions for everything that happened. Okay. All right. Questions, comments, concerns over here?
Nope.
Okay.
Not at the moment.
Oh, wait. Oh, STEMI. We're going to talk about STEMI. Okay. So what does a STEMI stand for?
ST segment elevation myocardial infarction.
Right. Okay. These look different every time, but they're
I
the
got
same
this one
kind of
wrong so many
concept.
times running through the cards that I made sure to drill this.
Okay, so STEMI stands for ST elevation, myocardial infarction. All right,
Can
so
you repeat
remember,
that? I'm
we're gonna
sorry.
go- Huh?
Can you repeat that? It cut out. I'm sorry.
ST elevation, myocardial infarction. So going back, way back to this picture here. Okay, so that ST segment right here, where it goes back to that kind of flat line before we have that T wave, if we notice, that's what it normally looks like, right? But if we notice a rhythm that looks like there's my T wave, here's my QRS, and instead of going back down to like that baseline before I see the T wave, if I see this entire segment is elevated, okay, that's not good. That is the indication that I'm confirming I have that elevation in that ST segment. I'm infarcting somewhere. So you're going to hear the term STEMI, and that's if you can see that in those squiggly lines on the 12 lead. You can see that positive elevation for that ST segment. Okay. that's just going to be confirmation. That's mainly what we look for to say, ooh, had a heart attack. So you'll hear a STEMI facility. That's going to just be a cardiac facility. Those are going to be the places who have been designated, and they have all the equipment. They have the cath lab, they have the surgeons, they have everybody ready to go. So if you figure out your patient's having an MI, make sure you're taking them to the appropriate facility so they can get the best in destination care. Okay. Now, any questions, comments, concerns?